Good evening, all my respected seniors and colleagues. I am audible
Yes, yes, you are. Yes, you are.
with warm regards from the city of marble. Myself, Dr. Roba Treasurer Job, welcome you all. Today, we are gathered here for a very important topic of our day-to-day practice, that is medical disorder in pregnancy. Starting with our session, I would like to invite and introduce our dynamic current President Jobs, Dr. Anuradha Dang Madam.
Hi,
Madam
Charles.
need no introduction. Madam is Director Suvidha Hospital. Madam is Vice President Job since 2015. She is very polite and humble person dealing with high-risk pregnancy since 20 years. She has a special interest in colposcopy and infertility. Madam has received various awards. I invite Madam and I hand mic over to Dr. Anuradha Dag Madam. Thank you.
Thank you. Thank you, Dr. Roma, for those kind words. Good evening, everybody, respected seniors and my colleagues of Jabalpur Obstetric and Gynec Society and all the members of FOXY who have joined in uh, with us for this TOG webinar today. Hope we all had a lovely Diwali full of joy, happiness, and positivity. Because this positivity is going to take us in a long run dealing with the difficult challenges that we deal every day in day-to-day life. Lately, we've been very, very busy managing our COVID-19 patients, neglecting some of the issues which were very, very important in pregnancy and could be even more life-threatening than COVID-19. And now that we realize that pandemic is here to stay for some more time, it is not gone as yet. So it is time for us to concentrate on the other issues as well, which need special attention. Thus, the need to arrange this webinar. Jabalpur Society is overwhelmed to welcome Dr. Komal Chavan Madam, the chairperson for the Medical Disorders in Pregnancy Committee. Madam has been instrumental in uh, connecting all these TOG webinars. She is doing wonders as a chairperson for her committee. She is working with such dedication. We welcome you, madam. We also welcome Dr. Archana Verma, madam. Uh, she is the Vice President-elect of North Zone for the next tenure. We know, madam, as the chairperson of Public Awareness Committee, Jabalpur, has very, very sweet memories of you, and I hope the same from your side. Also welcome Dr. Uday Thanewala sir, a very great orator, and today he will be guiding us regarding when to intervene in diabetes during pregnancy. Just a word about Madam. Madam Chauhan needs no introduction. She is the chairperson. Could I have the CV of Madam, please, Sana? Madam is the director of Chavan Maternity and Nursing Home. She is the chairperson of Medical Disorder in Pregnancy Committee. Madam is a very active member of Managing Council of MOGS and Managing Committee AFG. She's been the editor of Psychological Issues in Obstetric and Gynecology and editor of Monogram on Hematological Disorders in Pregnancy. Madam has lots and lots of awards to her name. Just to name few of them: Foxy Champion Awards, Wonder Foxian Awards, Dr. R.D. Pandit Award, Foxy Youth Mela Appreciation Award. Madam is a very dynamic person in herself, and we welcome you, madam, to the Jabalpur Society. And may I now request, madam, for just few words of blessing to our society. Dr. Komal, please.
Yeah, thank you so much, Dr. Anuradha, and you are one of those vibrant president of Jabalpur Society and doing fabulous work. And it would have been a great pleasure if this COVID was not there. I was very keen to visit Jabalpur this year, but because of now whatever Zoom we are meeting, and you're doing a fabulous work. Definitely, medical disorders in pregnancy. There are loads of medical disorders in pregnancy, but still now the dilemmas behind diabetes and anemia, the common ones, and the PIH are still leading. And I know that your society had a keen interest to know about diabetes, and I really thank Dr. Uday Khanawala sir to accept it and to enlighten and guide all our members regarding diabetes. So I'm really waiting to hear from him and as well as Dr. Archana Verma madam, who is the vice president elect. She will be talking about RH isoimmunization. So I'm really waiting for all the speakers, but I really wish all of you a great learning time, great webinar, and a great working in the Medical Disorders Pregnancy Committee. I also acknowledge Dr. Meena Srivastava and Nisha Sahu, who all have been there, the past presidents and pillars of Jabalpur Society here, and waiting to see you do wonderful work in the anemia-free campaign of the Foxy Medical Disorders and Pregnancy Committee. So I appeal to you to please send your entries. They're open. We are getting a lot of entries, a lot of enthusiastic Foxians, and so many. We get to see and know the thoughts of every member. It is really, it gives a real smile. Yeah, no, people can interpret in this way. This is a way. Our ideas only will go long ahead in conquering the impossibles. Like making every pregnancy safe, free of anemia, free of diabetes, free of hypertension. So thank you so much. Please unmute, yes, and Dr. Anuradha, unmute.
Thank you so much, madam, for those kind words. And moving ahead, moving on to the first session of this webinar, we have two chairpersons here. The first chairperson, Dr. Nisha Sahu, madam. Can I have a seat, please? Yeah. Madam is the past president of Jabalpur Obstetric and Gynec Society 2018-19. She's been the superintendent, the hospital that Dr. Archana was talking about. She's the superintendent of Rani Durgavati Hospital, Jabalpur since 2015. And during her tenure, she's won lots of awards for the government hospital. She's received the Kayakalp Award and 3 times consecutively in a row. So it is very remarkable. Also, madam has received the Lakshya Award, and she's been the participant of various conferences at the state level, at the national level also. The second chairperson for today, we have Dr. Meena Srivastava, madam. Once again, she's been a dynamic president of JOGS. As a secretary JOGS, she has worked very dedicatedly between 2008 to 12. She did a lot of work for the adolescent committee and detecting anemia and regarding the menstrual hygiene in the adolescents. And during her presidential tenure, she brought Jabalpur 2 very important national prizes for her work on reproductive health and population stabilization work. And we welcome you, Dr. Meena Srivastava, madam.
Thank you.
And the speaker for today, the great orator, Dr. Uday Khanawala. Can I have the CV of Dr. Consultant obstetrician and gynecologist at Navi Mumbai, is the vice chairperson of ICOG 2018 and chairman elect of 2021. He is of Medical Disorders of Pregnancy Committee 2006 and 8. He has a very strong academic career with lots of prizes, and sir is especially interested in ultrasonography, the maternal medicine, fetal medicine, and the high-risk pregnancy. So, sir, to hear from you regarding your talk on diabetes. Thank you, sir, for accepting our invitation. Dr. Uday, please.
Thank you very much, and very nice to be in Jabalpur. I mean, I remember my visit to Jabalpur when I think Dr. Rooplekha Chauhan was the president of his society. That is way long back when we did a labor workshop, and it was an amazing visit, and I really remember the warmth and the hospitality which we all have experienced in Jabalpur. So, Komal, thank you very much for getting me here with you, and we will do one thing. When COVID gets over, we'll go to Jabalpur together.
Yes, sure done, sir. I'm also waiting.
Yes. So thank you, Dr. Anurag, and thank you, chairpersons, for this talk. Now, when I was told to talk on GDM, what I felt was when Komal said, let's talk on something different, what I felt is that, well, when you talk about GDM today, it's come a long way from what it was when we started the work on GDM in 2005, 2006, when there was nothing standardized, there were no guidelines, there was no really people were doing what the West was telling us. And then we realized the incidence of gestational diabetes is very high in our society. And at that time, people were not even aware of the incidence or what to test, whom to test. So gradually, over the years, we've come a real long way in establishing what is Indian guidelines. You know, we have our own guidelines. We have the Government of India guidelines for GDM. We have standardized whom to test, when to test. We do a universal testing for all the pregnant women. When to test, we test them in the first visit when they visit us, and then we again retest them on 26 to on the 28 weeks of gestation, and at times at 32 weeks if required. And which test to do? So now we have focused and crystallized to most of us. It is feasible and easy to do the DIPSI test, what we call the 75-gram glucose 2 hour reading of glucose which we take in all pregnant women. So all that much is standardized. And even when you talk about the treatment, more or less it is now okay that we need to do we need to have diet and exercise followed. If that doesn't bring into control, yes, today the oral hypoglycemics have come up into use, and we can use metformin to control most of our diabetic patients. And of course some of them may require insulin, where they go on to the we take the help of our endocrinologist, or we are trying to bring up the level of our gynecologist on how to use insulin also in certain cases. So all that part is taken care of. So what basically now comes is the one of the important area is when to intervene in a case of gestational diabetes. So that is something which probably needs to be discussed a bit, because sometimes here again, when we have when we talk about the Indian standards, and we will look at it when we talk about the Western standards, how it is a little different. I'll just share my presentation. Sorry. So when does one intervene in a case of hyperglycemia in pregnancy? Now, this hyperglycemia in pregnancy is another term which we do talk about when we have it includes patients who already have diabetes, and then patients who include GDM. GDM we are more or less now reserving for patients who develop diabetes in pregnancy, which is 24 to 28 weeks gestation or later. And hyperglycemia in pregnancy is a term which encompasses now even pre-diabetes or diabetes which they have before they become pregnant. So let's go and see when does one intervene in a case of diabetes. Now, uh, let's start with this case when a 31-year-old gravida 4 para 0 abortion 2 and ectopic 1 presented at 27 weeks of gestation with intractable vomiting and upper abdominal pain. Her respiratory system CVS was normal and her blood pressure was normal. She had a BMI of just 23. In spite of symptomatic therapy, pain in the upper abdomen did not decrease. She became breathless and she had tachycardia. She was shifted to the ICU, and over there, when we investigated her, it turned out that her sugar was 480, 86 milligram per deciliter. So basically, she was in gestational diabetic ketoacidosis. So we do get complications of diabetes in pregnancy, and one needs to be careful. Of course, this was 5 years back. So it was a case of undiagnosed hyperglycemia in pregnancy, where only one random sugar was done in the first trimester, and a random sugar was only done. There was nothing else done to even try and pick up a GDM or a diabetes in pregnancy. She, of course, had an IUFD after 3 days in the ICU. Patient, of course, recovered because she was given insulin and the required treatment. But this is what happens, and one needs to know that now when do you interfere in diabetes. So if your patient by chance goes into something, a complication like ketoacidosis, what is happening to the fetus? Keto acids as well as glucose readily cross the placenta. So the baby is affected. Maternal acidosis, hyperglycemia, severe volume depletion, or electrolyte imbalance is detrimental effect on the fetus. Cardiotocography done during diabetic ketoacidosis in pregnancy has shown absence of baseline heart rate, variability, persistent late decelerations, and non-reassuring biophysical profile all suggest a fetal distress. The high mortality rate associated with diabetic ketoacidosis is basically due to a hostile intrauterine environment. So basically, ketoacidosis, if it occurs in the women, which is one of the complications of diabetes, the fetus can be affected. Now, is it an indication for delivery? That is the question which we are asking today. The natural inclination is to proceed with emergent delivery for non-reassuring fetal status that is frequently present during the acute episode. But it is imperative to correct sorry, but it is imperative to correct the maternal abnormalities first, because both maternal and fetal conditions will likewise improve. So, if you correct the maternal status, obviously the whole physiology will change, and the fetus may be even benefited and may come out of that distress which the baby is having. So, the decision for delivery can be challenging and must be based on gestational age as well as maternal fetal response to therapy. Does ketoacidosis, now suppose a patient has had ketoacidosis and you bring out the patient and then deliver, does it have a long-term effect on the fetus? The long-term effect of diabetic ketoacidosis episodes during pregnancy on survival fetus is lacking. Some studies have shown a direct relationship between plasma ketone levels in pregnant diabetic women and a low IQ in children. So obviously it does have some amount of effect on the fetus. Now, so basically, in a setting of poorly controlled diabetes, an individualized decision aiming for late preterm or a early term delivery before 38 weeks, point 6 days is recommended. An early term or term delivery, that is 38 to 39 weeks plus 6 days gestation, is suggested if vascular complications are present in women with pregestational diabetes. So basically, this is from the American College of Obstetrics and Gynecology, where they say that take the patient, if possible, till at least 38 point plus 6 days of gestation, or an early term delivery, that is 38 to 39 weeks of gestation, if vascular complications are present in a case of diabetes. But if the patient has got well controlled diabetes, for a woman with well controlled diabetes, whether pre-gestational or gestational, a late preterm or an early term birth, that is before 39 weeks of gestation, is not indicated. So here you have one concrete answer, that if your diabetes is well controlled, if she is not on insulin, if her sugars are well controlled and there's no effect on the baby and the baby is doing well, then there's no need to deliver a diabetic patient before 39 weeks, completed 39 weeks of gestation. So if you look at the Western recommendations up to date 2018, and if you see what they state here is gestational diabetes, if it is diagnosed, uncomplicated pregnancy on nutritional therapy alone, you do an ultrasound to estimated fetal weight at 37 to 39 weeks. And if your weight is more than 4.5 kgs, then of course counsel and schedule for a cesarean delivery at 39 weeks. But if the estimated fetal weight is less than 4.5 kgs, counsel and offer trial of labor and expectant management until 41 weeks. Now, we will discuss this, whether we agree with this or no. But if you have an uncomplicated pregnancy, poor glucose control, or nutritional therapy, or using insulin, means that your diabetes is not under control, do the proper fetal surveillance and do an estimated baby weight at 37 to 39 weeks. And this is earliest one can probably interfere is 37 weeks in this case. Again, we need to discuss certain points over here, like estimated baby weight less than 4.5. I think in our conditions, in Indian conditions, we would take anything above 4 as macrosomia. And if the baby weight is more than 4, we would counsel and offer them maybe trial of labor with the full awareness that this baby is going to have a little bit of a difficulty in delivering, and you have to have your shoulder dystocia drill, etc., everything ready. And then probably will not wait till 41 weeks, because we in India, we know that we have complications like meconium aspiration or sudden IUFDs, etc., which can happen after 40 weeks of gestation in even normal patients. So here we are talking of a gestational diabetic patient where we are worried about a sudden stillbirth after 38 weeks of gestation. So I don't think we are going to follow this and take it up to 41 weeks. And even when it's uncontrolled diabetes, how much do these non-stress test or amniotic fluid index help us? We will just discuss that in a moment. And again, cesarean delivery at 39 weeks, uncontrolled diabetes, I doubt it. I think we will be doing it much earlier. So that is where we have to again come a little bit different than what standards stay. So the Government of India guideline says that the timing of delivery in a well-controlled patient decided for delivery after 39 weeks. That is accepted, and that is what everybody is saying. But poorly controlled diabetes with risk factors to be optimized by the obstetrician. So here again we have to come to our own thing that how to deliver is basically the obstetrician's thing. So a little more insight into this. What happens in clinical practice? It is okay to have guidelines in front of you, but what happens in clinical practice? Let's talk about all the places, not only Jabalpur, but you must be training a lot of patients from outskirts of Jabalpur. How do you deal with them? We train a lot of patients from Navi Mumbai and far away places like Roha, Panvel, etc. So in practice, however, these gestational ages may be difficult to attain. It must also be remembered that these recommendations assume 24 by 7 availability, accessibility, and affordability of optimal maternal and fetal monitoring, including 7-point glycemic profiles and regular cartography for all women with GDM. They also take certain attributes of fetal environment, such as ease of travel and communication for granted. The distance of these women with GDM which a woman has to travel to access healthcare, the ease with which the journey is negotiated, and the feasibility of regular frequent follow-up is also influence the mode and timing of delivery. Now imagine, even especially in COVID times, I mean, COVID has made things so difficult and problematic that one has to think whether we can really follow only these guidelines and wait till 39 weeks. Early induction of labor may be appropriate for women who find it difficult or expensive to travel repeatedly to the healthcare center or who are unable to adhere to the recommended frequency of follow-up. So suppose a woman she's got uncontrolled diabetes and she can't keep coming every week to the clinic, or so she needs to be admitted, or a woman who's got well-controlled diabetes also, you want her to come very often, she may not be able to follow that advice. So you may have to, admit her at around 38 weeks and say, okay, now enough, now let's just deliver you and get this baby out, which is now ready for delivery and there's no other problem with the baby. So one also has to think in the environmental factors, antenatal steroids. Does she require admission for it? Because please remember, in a case who is of a poorly controlled diabetes, if you want to give antenatal steroids, this is one thing that may just take the sugar off balance, and it is one of the causes which leads to ketoacidosis. So, sometimes they may require admission for antenatal steroids. Availability of medical expertise, like to manage hyperglycemia due to the antenatal steroids, for assisted vaginal delivery, or facilities for LSES in the far-flung areas or in the interiors. They may not, in the primary health centers, they may not having so much of facility. And neonatal care, if you don't have a neonatal care to bring out this baby and to care for it in the neonatal, you may not be able to do an early delivery. So lack of neonatology or medical expertise supports the decision to continue women with GDM to term, rather than have risk a clinical situation where the mother with an iatrogenic hyperglycemia secondary to antenatal corticosteroids or preterm neonate deliver timely because it cannot be managed. So basically, it is okay to have guidelines. It's okay to know, okay, uncontrolled diabetes 39 weeks or otherwise wait till 38. But a lot of other factors come into play. And we all have been practicing in our private settings or in the government setting for a very long time. And we know that there are certain factors which we need to just take into account. So when you see factors influencing timing of delivery in GDM, let's talk about the factors which favor an early term delivery. An early term, we mean less than 39 weeks. So if you have a past obstetric factors like previous pregnancy loss, history of previous IUFD at term, history of macrosomia, or a history of previous cesarean section. In the current obstetric factors, history of loss of fetal movements. She's complaining of loss of fetal movements. You need not keep on waiting. Macrosomia, expected fetal weight is more than 4 kilograms. IUGR, or a compromised placental maturity. Like, these are another factors which we will talk about shortly. Medical factors like uncontrolled diabetes, or if the woman with uncontrolled diabetes also has retinal complications, renal complications, compromised cardiovascular health, all these factors will also say favor an early delivery. Psychological factors, patient's request for an early LSAS, yes, one can even consider that. And social factors, availability of neonatal care, ability to provide corticosteroid coverage, inability to come for frequent follow ups, and patients having to travel long distance for obstetric or medical care. So, all these factors would favor an early delivery. Now, when they say less than 39, you probably would even say around 38 weeks of gestation. Favoring term delivery or more than 39 weeks of gestation when there is no bad obstetric history in the patient, when there is optimal fetal maternal health, when there is well controlled uncomplicated diabetes, patient is reluctant for an early delivery, or lack of specialized neonatal care, inability to provide corticosteroid coverage, or if the facility is close by to the where the patient is staying, then yes, of course, you can go on to wait till 39 weeks. Maybe what we are saying is between 38 weeks and 39 weeks. For early preterm, we would probably say 37 and 38 weeks, where of course in gestational diabetes, we want to wait till around 38 weeks of gestation. So basically, it is a shared decision making. The patient, her family, including the husband and mother in law, should be consulted about the potential benefits and harms of an early delivery. Her views and preferences must be ascertained and taken into account while taking decisions. Input from other medical professionals who are integral part of the GDM care team should also be considered. Maternal and family attitudes towards cesarean section ascertained, and suitability or risk stratification for anesthesia must all be taken into account while planning a delivery. Now, in clinical practice, most clinicians are scared of a sudden stillbirth in GDM, and generally in India, we want to terminate pregnancy at around 38 weeks of gestation. And even the NICE guidelines say that yes, at 38 weeks, discuss delivery and offer delivery to a patient who has got GDM. So, when you talk about stillbirths, is there any investigation which will help us in preventing a stillbirth in a diabetic? No, there is nothing which will point that this patient can land up with a stillbirth, because the cause of stillbirth is still uncertain. It could be due to relative fetal hypoxia, which increases the risk of intrauterine fetal death, or it could be also due to placental vasculopathy, venous edema, maternal ketoacidosis, which is occurring you are not aware of, electrolyte disturbances, fetal hypertrophic cardiomyopathy is another disorder which has now come into the forefront, and it could be the cause of a sudden stillbirth, which sometimes we see and everything is going well, and a patient of GDM suddenly lands up with a stillbirth. So we really don't know what causes a stillbirth. So, what about antenatal testing in a case of diabetes? Now, the frequency, type and frequency is determined by the severity of maternal hyperglycemia or presence of other clinical adverse effects. Like we monitor the fetal movements. Of course, we ask her to do a kick count from in the last 8 to 10 weeks of pregnancy. NST should be considered after 32 weeks of gestation, and in women with insulin, or at near term those who are on diet control. Doppler is used to assess the umbilical blood flow, and of course it's a very important thing to be done, which I'll just elaborate in a while. Now, but when it comes to the recommendations, there's nothing sure shot offered, because even the FIGO guidelines say the use of cardiotopography and biophysical profile or kick count as indicated according to local protocols. So one has to make their own protocols on how often they'll do NSTs, how often they'll do sonographies, and how often they'll do a Doppler in a patient with GDM. So if you have a GDM with where the patient has gone into a growth restriction or has a small for gestational age baby, then of course there are guidelines which are very clear. Bi-weekly sonography and Doppler studies of the uterine and umbilical vessels should be used for follow-up of SGA fetuses once picked up. If Doppler results indicate that the fetus is beginning to decompensate, delivery should be planned regardless of fetal age. So basically, all your GDMs should undergo sonography mostly once a month, especially after 20, 22 weeks of gestation, to pick up any gestational growth disparity in the fetus. And if it is a small for gestational age fetus, or the baby is not picking up enough weight, means the patient has some vasculopathy, and that is the reason there is a problem. And these patients will do good on a Doppler surveillance. So in SGA, Doppler is a good surveillance tool to judge and predict the turning point at which the decreased perfusion adapted fetus decompensates and delivery is necessary. So in SGA, of course, you will get a good result from a Doppler. So monitor them with Dopplers, monitor them with NSTs, and if there's any change of Doppler, your MCA is going higher, your umbilical flow is going down or absent, deliver these babies irrespective of gestation age. So another point here is that all your diabetics don't hesitate to give steroids, because once they reach mature, once they are 28 weeks onwards, maybe if once the sugar is a little bit under control, it is better to give them steroids, because you may land up with a early delivery in many of these cases. So think about steroids and don't hesitate to give steroids to these patients just because they're diabetic. So in contrast, for a large for gestational age fetus, if the sugar has affected the baby and the baby weight is more and there is fetal macrosomia, this baby will have a placenta which is usually large as well, and there is an increased blood flow present, and the wave curve is normal, such that the usual perfusion indices fail to predict placental insufficiency. In these babies, Doppler will be misleading and it will not give you the correct picture. So, unlike intrauterine growth restriction in diabetes, metabolic derangements in the fetus may lead to acidemia without hypoxemia. Therefore, the classical redistribution seen in the fetal hypoxemia due to uteroplacental insufficiency may not occur even in a severely compromised fetus which is large for gestational age, and therefore it is important not to be misled by an apparently normal Doppler result. What about AFI? AFI, the measured amniotic fluid less than 2 centimeters, is considered to be significantly reduced and should prompt delivery. A relative hydramnios may occur in GDM, which we know because GDM patients generally have hydramnios, and this may mask a low AFI because of limitations of the predictive value of most of the fetal monitoring methods like AFI and Doppler, and lack of randomized control trials to support fetal monitoring methods. There is no agreement on the best way to monitor. So basically, the AFI is not helping us, the Doppler is not helping us unless the baby has got a small, is already having a bit of IUGR. So we are basically left more on clinical judgment to judge how this patient is doing. And that is why most obstetricians would probably want to deliver around 38 weeks or 39 weeks and not keep waiting longer unless it's absolutely uncomplicated and a regular case of diabetes. So basically, what about ultrasound? What about macrosomia? Do you deliver because the baby is heavier in weight? Do you deliver early and get away with a normal delivery? What about the the diagnosis of macrosomia on ultrasound? Basically, the sensitivity is not very good, the specificity is good, the negative predictive value is good, but the positive predictive value is very good. Means what we are trying to say is whether it is ultrasound or it is clinical palpation, all methods of judging of fetal weight are approximate, are not really very accurate, and ultrasound may overdiagnose macrosomia, but in generally, we all do take help of an ultrasound. So in an ultrasound, if you get that abdominal circumference, which is the most important thing to measure in ultrasound for the baby weight, if that is coming around more than 40 weeks, even at 38 weeks, be sure this baby is heavy. This baby, whatever the weight it calculates, 3.7 or 4, there may be a difference of 2 grams here or there. So basically, the risk of cephalopelvic disproportion and shoulder dystocia increases as the fetal weight gains occurs with advancing gestational age. So the chances of a normal vaginal delivery therefore may recede as gestational progresses in women with a refractory GDM. So if the woman is having macrosomia, do we induce and deliver her early in case of to save the patient from undergoing a cesarean section? So induction of labor does not change perinatal outcome in a non-diabetic patient. So these are studies from the Royal College which have shown But in a diabetic patient, induction of labor reduces shoulder dystocia and improves perinatal outcome. So when the patient reaches 38 weeks and the weight is more, it may be wiser to induce and deliver her rather than keep waiting for that weight to go more, or because after 38 weeks, I really don't think we're going to gain any maturity or lung maturity in the baby. So if one is sure of dates and 38 weeks is reached, generally we want to deliver. If the weight is already heavy, it may be better to induce them at 38 weeks and deliver them so that we can prevent shoulder dystocia and improve the perinatal outcome. So, do we worry about delivering the big baby? Well, the risk to the mother and baby are infrequent, but the risk to the mother and babies when they occur are profound, because you can have something like an Erb's palsy, which is a permanent thing. The baby's sort of hand goes for a toss throughout the life. So we are risking too much over there. Of course, the maternal tears, etc., also do occur, which can be very problematic if they have a third degree tear, etc. So basically, it's a balanced obstetric decision making as usual on how to deliver them. So is macrosomia an indication for LSES? Although the diagnosis of fetal macrosomia is imprecise, prophylactic cesarean delivery may be considered for suspected fetal macrosomia with estimated fetal weights greater than 5 kgs in women without diabetes and greater than 4.5 in women with diabetes. Maybe in our condition, we will probably take as 4, and anything above 4 as macrosomia, and we need to clinically decide whether this woman undergoes an elective cesarean section or one goes ahead with delivering them vaginally. So considering ethnic difference, these thresholds should be lower, and approximately 545 cesarean deliveries would be needed to prevent one permanent brachial plexus. But brachial plexus, believe me, is the major contention of in the courts when it comes to cases against obstetricians, and it's a bad complication to have. Now, sometimes hydroamnios may warrant a termination of pregnancy. Respiratory embarrassment, if it occurs so much, the liquor is so much that your medical management, like indomethacin, is not working, then you may need to probably say, okay, now 37, 38 weeks, there is too much of distress, let's deliver the patient. Amnio reduction one can think of if the baby is still premature. At delivery, of course, hydroamnios does pose a problem like uterine dysfunction in labor and PTH, so one has to be very careful of this complication when it occurs. So basically, it's a nice paper from Bharti Karlag in, I think, Punjab, where they said the shared decision making can be considered in situation characterized by clinical equipoise where more than one therapeutic option is available. For example, a woman with GDM with a good sized baby, more than 4 kgs on abdominal or ultrasonographic examination, presenting at 37, 38 weeks with a history of recent weight gain and favorable cervical findings on per vaginal examination may be given an option of induction of labor. On the other hand, a scenario with maternal distress or fetal distress leaves no room for prevarication. Informed consent for labor induction is absolutely necessary to ensure maternal and fetal well-being. So a lot of work has been done on this, and ultimately one has to make a informed and a proper decision to help the patients and deliver them normally. Now, when you talk about interference, let's have a last word about termination of pregnancy, because pregnancy is compromised by pre-GDM have a 3 to 4 fold increase in incidence of congenital anomalies as compared to the general obstetric population. The prevalence of malformation appears to increase with the degree of diabetic severity, and higher proportion of CNS, CVS, kidney, and GI malformations have been reported. So when you get a diabetic early in pregnancy and you feel that your 75-gram glucose test is 170, 180, you do an HbA1c. And if the HbA1c comes to around 8 or 9, then what do? You have to just inform this woman that, look, the risk of your having this baby having a congenital malformation is around 25%. If it is less than 8, just 5%. If it is less than 6.5, maybe we really need not worry about congenital malformations. But if the HbA1c is high, uh, earlier many people I would hear say that let's terminate pregnancy, but that is not the way, because today we have enough evidence. The ultrasound is there to our rescue. And if you do a proper ultrasound and a complete anatomical survey can be achieved in 64% of abdominal scans and 82% of TBS scans at 11 to 13 weeks of gestation, and a complete cardiac evaluation. We are worried about cardiac anomalies in GDMs, and even those they can pick 45% at 11 weeks, 90% at 12 to 14 weeks, and 100% at 15 to 18 weeks. So our machines are so good. Our caliber of diagnosing congenital malformation is so good, and we of course have the other things like Down syndrome, etc., doing the biochemistry for them. Please remember when you send a biochemistry for Down syndrome, do mention diabetes, because they have to add a factor there to change the result. So all these things, but we have those tests. We can do the test and tell the woman, look, it seems reasonably sure that your baby is completely normal. Yes, one can be in for surprises because small cardiac defects, etc., sometimes are missed. So one has to leave it to the patient. The risk of abnormality is higher, say around 25 to 30%, and even when the HbA1c is more than 10, but that means 70% of the babies will be normal. So it is their wish if they want to take that chance or no. And of course, if we discover a congenital anomaly, it is a safe termination can be advised. So do that 11 to 14 week scan or 13-week scan in a good center where they can pick up abnormalities, especially for diabetes. So basically, when to terminate pregnancy or when to interfere, waiting at least until 38 completed weeks of gestation improves fetal outcome, because we know maturity in diabetics is reached, lung maturity is reached a little late. However, if an indication of early delivery exists, GDM should not be considered as a contraindication to proceed with interventions for early delivery. Also, if a spontaneous preterm delivery seems imminent, it should not be postponed. At times, in fact, an early planned operative delivery may be appropriate for women with ketosis or ketoacidosis, difficult to control diabetes with frequent episodes of hypoglycemia or hyperglycemia, excessively high insulin requirements, or any other clinical situation which may put the fetus at risk. So this may also be true for women with compromised cardiovascular, renal, or retirement function. So that is what it is for GDMs. One has to be very, very alert in these cases when to deliver these cases. Thank you all very much. And if you manages our GDMs properly, we definitely have a healthy generation next. Thank you so much. You need to unmute, I think.
Thank you, Dr. Thanewala. You have given a very nice elaborated talk, and it clears many of our doubts. Really, it is a beautiful talk given by you that when to intervenes in the pregnancy in case of diabetes.
Thank you very much.
Thank you so much.
So, any questions from the audience?
I only want to say that it was the most fantabulous talk I ever heard, and it was really a master stroke.
Thank you, Archana. It's very nice of you to say that. I think it is just bringing together of what we all already know. It is just putting it in.
But still, sir, there is a way of presentation, and the who is talking matters.
Thank you so much.
And basically, he has covered all the clinical scenario where, like, obstetrician has to intervene and to do the delivery. And definitely, guidelines says differently. But after 38 weeks, we are on high alert in the diabetic patient.
Yes, that's what I said, that in India, we really don't go with 30, and I mean, 41
Yes.
weeks, we would probably never wait in diabetes.
Yes, even after 37 weeks, we are on alert.
Yeah, very much alert after 36 weeks onwards, and 38 weeks,
Yes,
I
anytime
must
we
draw a
can.
line and think of delivering here. Of course, if the diabetes is under control and she can be induced, go ahead with induction and get a good baby out. So that is what it is.
And every obstetrician has come across sudden death cases in this. I mean, even in normal pregnancies, and even GDM also.
And if I could just add one, I mean, maybe we miss out the cardiac evaluation at 11, 13 weeks when we are sending the patient for scans. So maybe, we should also concentrate more on the cardiac evaluation of the fetus then.
But anyway, has to be repeated. Whatever you do, the cardiac evaluation of the fetus has to be repeated at 18 weeks gestation so that one can pick up if there is any abnormality.
Because once I had a mishap because a diabetic patient with severe bradycardia, I thought, we'll be losing the baby. I did a section for her. And then I came to know later on that it was a cardiac malformation. So, I mean, I felt very bad, for not...
One of the leading causes of stillbirth also is said that maybe there is hypertrophy of the intervening septum, which ultimately, if the baby survives and comes out after 3 to 4 weeks of delivery, it may come back to more or less normal. But that is one of the causes of stillbirth, what they have stated in babies with diabetes, of diabetic mothers.
One thing I want to add on, if she is on insulin, we have to take care of hypoglycemia. Because
Yes,
this
yes.
is a major problem in the patient of GDM. She is on insulin.
Yeah. The patients on insulin require very, very close monitoring and very quick decision making on when to deliver them.
Yes.
You can't keep on prolonging their pregnancies.
I need to say
The retinal examination in the regular antenatal checkup of these women? Like at what weeks we have to offer the retinal examination of these women?
6 months, 24
Retinal
weeks.
examination is more in patients who are known diabetics. So when they
Okay.
conceive, before conception, ideally they should undergo a retinal examination. They have to see the kidney function, and they have to see all those things. But retinal examination at least once or twice in pregnancy has to be repeated, especially at the beginning of the second trimester and maybe one in the third trimester. If she is a known diabetic already on insulin, etc., then a retinal examination
Okay.
needs to be done routinely. You have to refer them to an ophthalmologist.
Okay. Thank you. Thank you.
Dr. Vivek Halawala.
Yeah, thank you. Yeah.
Very nice presentation. I really like that the concept of husband and mother-in-law in your presentation. That's very nice of you to say. Regarding the sudden fetal death, I used to do the high-risk pregnancy clinics in UK. We asked them to manage the diabetes and sudden really rising blood sugar, sudden drop in blood sugar.
Yeah.
Hyperglycemia and hypoglycemia may be the cause of sudden fetal demise in diabetics. So we have to tell them that keep your blood sugar more or less constant. Never go for hypoglycemia.
Very true.
Hyperglycemia is still manageable other than hypoglycemia. That's all I can say. Very nice. Thank you very much. Thank you very much.
Patients should be told that they cannot let them go into hypoglycemia. That is why self-monitoring is very important, and it's better to keep the sugar a little bit on the higher side rather than the lower side.
Yes, sir. Absolutely.
Excellent.
Thank you, everybody.
Thank
Thank you,
glimpse
Dr.
of
Uday.
diabetes and
Thank you
every
very much.
aspect was so well covered, and a lot of queries still come. We still are in a dilemma when to deliver and all. I think it was very fantastic talk, and I think questions maybe audience will be answering because it's online. It would take time. Are there any questions? Support?
Sir, one question from my side.
Yeah.
Many times we see that patients with family history of diabetes, though their blood sugar is normal, still they have a repeated pregnancy loss, especially first trimester. How do we explain it? Just early pregnancy losses, their mother or father are diabetic, but the patient is absolutely normal. There is no the blood sugar is normal in all her G75 reports, but still they go into missed abortions. How do we
So
explain?
then the cause may be totally different. It could be any of the other causes of missed abortion, whether you call an apnea syndrome or a uterine malformation or anything else which can cause or genetic. But then it is not because of diabetes. If the patient doesn't have a high blood sugar, there's no reason. Just because her parents are diabetic, she gets an abortion. That is not the reason. You can't attribute it to her family history of diabetes. No.
And even in IUFD, many times we find that the blood sugar is normal in the patient and still the patient undergoes IUFD.
Yeah, see, causes of IUFD are quite a few. We sometimes suddenly have an IUFD and we find everything else is normal. So those cases one really can't explain only on sugar. What we have to do our best to find out if the woman has got an abnormal sugar. But if the sugar is normal, then it's not necessarily that problems will not occur. Because yes, you have to just keep a watch and do the proper test to make sure that the sugar is normal. That's all. It's not correlation otherwise.
Thank you, Uday sir. Thank you, Chairperson, for chairing the session. It was a brilliant talk, sir. We really enjoyed, and with very clear take-home messages as regards the private practice. Thank you so much.
Thank you so much.
This is the end of first session and the beginning of the second. In the second session, we have chairpersons as Dr. Vibha Gehlot, Madam, Madam has worked in UK. Could I have the slide, Sana, of Dr. Gehlot, please? Yeah. So Madam has worked in UK for 23 years. She's an accredited colpologist and trainer colposcopist from British Society for Colposcopy and Cervical Pathology. She has special skills in advanced hysteroscopy surgery. Basically, Madam concentrates too much on the outpatient hysteroscopy, and Madam has received lots of training in UK for the hysteroscopy, and she's a master here in Jabalpur for the hysteroscopic surgeries. And above all, she's a teacher at heart, and she has received 8 times the Teacher of Month award from the Oxford University. We welcome you, Madam, to our society.
Thank you very much.
The second chairperson for the session is Dr. Sangeeta Srivastav. She is the past president of JOGS in 2014, and during her tenure again, she brought lots of prizes for Jabalpur. She was the winner of Foxy Durusha Award Trophy and Dr. Chitra Dhara and Dr. Gangadharan Preventive and Research Oncology Trophy. Recently, Madam, in the last tenure, she was the president of IMA Jabalpur, and there also she did wonders with her work. She received the President Appreciation Award at IMA MPCon 2019, and she's done tremendously well as an IMA president as well. We welcome you, Sangeeta Madam. And the speaker for this session, Dr. Archana Verma. May I request the chairpersons to introduce the madam, please.
I have a great pleasure in inviting Dr. Archana Verma, who is well-known and renowned personality, Vice President Foxy North Zone, past Public Awareness Committee Chairperson from 2016 to 2018. She won quite a lot of awards. The Best Presidential Committee Award, Abdul Kalam Excellence Award, Women of the Year Health Award, Organizing Secretary of North Zone Yuva Foxy 2016. She has been Organizing Secretary of UPCOG Midterm 2015. She has done excellent work and the recipient of India Book of Record. Dr. Archana Verma needs no more introduction for this because she's a well-known personality and is presenting or telling us about the ISO immunization, which is in itself is a very confusing. More you read, more you get confused, and when it comes to clinical management, it is most difficult. I have a great pleasure inviting Dr. Archana Verma to talk to us with your ISO immunization. Thanks.
Thank you, Madam Vibha Gehlot. By the way, I am also Gehlot from my family tie. So we are from
Rajasthan.
Rather, I am very much nervous with the most elite chairpersons. And after the wonderful talk by none other than our Dr. Uday Thanawala, please bear with me. Dr. Komal Chavan has given me the responsibility of this talking for this ISO immunization, and I hope I can do some good work. So we all know that there are many things we plan and more adjustment we do whenever there is a marriage is a fix, and we do everything, making list of guests, printing invitations and booking of venue, and of course all ceremony dresses, jewelry and everything. But hardly do we pay heed to the medical concern regarding any later on about the partner also, no blood test and nothing. We don't do anything. We don't even think of anything. But does it really matter? but because whenever the most common thing is a difference in the compatibility or in the blood group systems. So just to say one thing from my side, it is good to be aware of the blood group, but definitely difference in blood group is not a that happiness killer. If the blood groups are different, then you need to knowing the partner's blood group may be very good whenever in emergency you may need anything, and in help in taking recommendation of the medical approaches. So knowing the partner well is well recommended, and think of the this blood group also. And among the many disappointments, there is always a light of hope everywhere. And whenever a couple comes to know that we are different, our baby may suffer, they need not worry a lot. And about immunization, it is actually the production of antibodies in an individual in response to a foreign red cell antigen, and it's derived from the same individual. So we all know that there are ABO blood group and the RH blood group. ABO is as we know that ABO, there's a presence of antigens and antibodies which makes this difference. And O negative is one of the very rare blood group, and this rare O group, and this rhesus blood group, there are actually so many systems and this group available, but we know mainly the five important types. And this about was a bit about RH antigen. RH antigen, actually this RH system is a one of the we call it it's an abbreviation of the rhesus, so we commonly call it RH. And RH system was a second most important blood group system, and it was told by rather in when the Landsteiner in 1940 along with the Wiener, they injected a rhesus monkey blood into the rabbit, and it created antigenic reaction. And genetically it's on short arm of chromosome 1, and RHD among all the five is the most immunogenic, and a person lacking D antigen is called the RH negative antigen. And in India, it's this thing is around 5 to 7%. And RH person, RH type is generally most relevant with respect to pregnancy. And if both the couples are RH negative, then you need not worry. And who is we need to know who is the miscreant in RH incompatibility, and it is the this placental barrier. Placenta acts as a barrier, and to this fetal blood mixing into the maternal circulation is limited. And however, sometimes during pregnancy, these small feto-maternal hemorrhages can occur, and women immune system react to this, and it causes a reaction. So this broken barrier sometimes is called, which happens is called feto-maternal hemorrhages, and chances of antepartum FMH is around 10%, and in postpartum it is 90%. And the amount of the fetal blood necessary to produce antibody can be as little as 0.1 ml of RH positive cells. And this is an infographic representation of the pathogenesis, where this actually RH negative mother carrying the RH positive fetus, and the entry of the fetus RH positive RBC into the maternal circulation via the feto-maternal hemorrhages, and it causes the development of the RH antibodies. And there are two types of reactions, primary and the secondary. And this points to mainly remember is if 1 ml of RH positive blood enters, it chances are the of this creation this incompatibility are 15%, and primary response is dose dependent, and secondary response is initiated even with the 0.03 ml of the blood. And this is the list of the feto-maternal hemorrhages. You can see, and it occurs 5% in the first trimester, and the third trimester the chances are quite high, and maximum is at the time of the delivery. And blood history of This blood transfusion is also equally important, which we must ask the patient also, because sometimes we say that she's a primary patient and how come she is having this much. And in spite of all the antenatal and like we are taking all the care, we are giving injection anti-D. All the gynecologists, they whenever they just, as soon as they see the RH group, they do all the Coombs test and everything. But still, it is though it is very less, but it is still occurring. So there are certain cases where, in spite of all the antenatal and postnatal prophylaxis, 1 to 3% can develop antibodies. And there are this test for fetal-maternal hemorrhages are mainly the Cleohars-Betke test, and this is Rosette test. So when you find a patient of RH negative, the main aim of antenatal management is just to predict which pregnancy is at risk, and to predict whether or not fetus is affected, and to correct the anemia in fetus and reverse hydrops by doing all the invasive tests and invasive management, and to deliver the baby at right time, preventing the preterm births also. And objective are, number one, if the woman is non-immunized, I mean, there is no iso-immunization has happened, then there is a prevention of the allo-immunization. And once she has been immunized, then early detection and adequate treatment of the fetal anemia. Actually, previously we used to call it the hemolytic disease of the neonates. So it is mainly causing because the antibodies are going via placenta to the fetus, and they are killing the RBC. So mainly only the problem is fetal anemia and jaundice, of course. So once the patient comes to an antenatal, our main objective is to take history. If the patient is a primary with no previous history of blood transfusion, we know it is very unlikely that the baby will be affected. And in a Paris woman, a detailed obstetric history, taking the classical history of fetal getting affected in as if history of stillbirth or neonatal deaths due to the severe jaundice following 1 or 2 cases is highly important. And this history of injection, sometimes the patient say हमको एक abortion के बाद डॉक्टर ने इतना महंगा सा इंजेक्शन दिया था या आफ्टर डिलीवरी दिया था, even if she is not telling the blood group, so that is also quite suggestive. So if the RH negative mothers, you diagnose, then you do the husband blood group. If the husband is also negative, there is no problem. And as such, the routine antenatal management of the singleton pregnancy, if it is there, then like any antenatal patient, you carry on taking into consideration all the maternal and the fetal surveillance as usual. And if the husband is RH positive, then go for the indirect Coombs test. And then sometimes determining fetal RH factor is also possible, but the cost effectiveness is there. And but some by doing CVS, and we can or by doing cell-free DNA, it can also be done in the maternal plasma, though the cost matter, but sometimes prevention is better than cure, and we are quite confident of the blood group. And then we can avoid anti-D injection also, and so many invasive tests. And this indirect Coombs test is done, and it tells us what is the antibody. If it is positive, then we start taking the antibody titer. This is a serial maternal anti-D, is done every 2 to 4 weeks depending on the titration. And the critical value is to remember is at the one at which the hydrops can develop. So and it's typically between 1:8 to 1:32, because it differs in different labs. And the problem of sometimes, this is a very important to note, that severity of disease may not be dependent only on the quantity or the antibody titer, but also the maturity of the fetal immune system and type of the different antibodies also, because we generally test only anti-D, and patient because there are different type of antigen also, and antibody may also be present. And then this screening of alloimmunization in the first pregnancy is done at the first booking, and then at 20 weeks, and preferably 28 weeks. And in subsequent pregnancies, if there's a history of previous pregnancy with mild or no hemolytic disease, then done at the first booking, and then every 4 to 6 weeks subsequently. We have to take care that sometimes there's are chances of involvement of the fetus for the anemia, development of the anemia. And if there's a previous pregnancy with severe hemolytic disease or stillbirth or neonatal deaths, then we best is to transfer or refer the patient to the specialized center of the or the fetal medicine specialist. So the once the this it's a very simple slide saying that if the indirect home test is negative, then it means it is there's no isoimmunization at present, and the management of the non isoimmunized just like as if it was not isoimmunized. And our aim is to minimizing the chances of feto-maternal hemorrhages, because as we saw in the list, we should not do that thing or the suction evacuation and giving that time, or preventing this, and preventing aluminization by giving anti-D. And generally preferred is 28 weeks of gestation. If the ICT is negative, then the anti-D injection is given. And if it is positive, then there's no need to give anti-D, because it is not going to help the patient. Or within that, then 72 hours of delivery, we will tell later on. And if it is indirect positive, then it is this is called RH isoimmunized pregnancy, because this pregnancy is properly is a risky pregnancy. So it is very important to assess the antibody titer, and if the taking mainly the critical titer as in common practice 1:16, and if it is less than 1:16, then indirect Coombs test is done roughly every 4 weeks, and then deliver at 37 completed weeks, and keep on monitoring for the fetal anemia by ultrasound and fetal Doppler. And if it is mainly more than 1:160, then the middle cerebral artery peak systolic velocity nowadays is very, very common. And because since this has come, though it is not very effective after 35-36 weeks, but still it is one of the best technique which has come to detect the fetal anemia. And nowadays the amniocentesis and all are not being done. And this generally it is the hemolytic disease of the fetus and newborn are categorized into mild, moderate, and severe. Mild is when it is the hemolysis is well tolerated by the fetus, and moderate is when there's a increased destruction, but not that much. The patient and that the fetus is developing too much of anemia. And these are the patient who after the delivery they show all the signs of anemia and hyperbilirubinemia, and kernicterus develops in them. And they post delivery treatment mainly for the fetus, and they may require the blood transfusion also. Severe are the one where there's so much of fetal destruction, fetal RBC destruction, that fetal cardiac failure and fetal generalized edema develops. This calls hydrops fetalis, and it may lead to stillbirth, and if less than the neonatal death. And the testing for this HDN is by ultrasound. And CVS also, amniocentesis, chordocentesis, and CNPSV. These are the list of this thing. CVS, because we do know so many things, but because it is not being done regularly by all the by clinicians, and a little bit of complicated, but if mainly by the fetal medicine specialist. And on ultrasound, we see the signs of fetal anemia in a form of a polyhydramnios and hyperplacentosis. Hyperplacentosis is actually is occurring because it's an effort to increase the transfer of oxygen, because the body system adopts and fetus is requiring more and more of the RBC, and so it starts developing more and want to send the more of the blood, and there's a development of the fetal ascites. These are the changes occurring because of the so much of hemolysis and hepatosplenomegaly, and increased right atrial size because of the heart failure, and the hydrops fetalis also develops. And hydrops fetalis, the classical sign is this Buddha posture. Sometimes we see an halo sign because of the subcutaneous edema of the scalp, and there's a ground glass placenta, and their ascites is also there, and sometimes pleural effusion is also there. Maternal effects of RH elimination sometimes because of the hyperplacentosis. Preeclampsia type of thing can occur. This is not very common, but I just wanted to show this slide because it's called Valentine syndrome, where the baby and the mother, they look same because of the PIH symptom. The baby is also swollen, placenta is also swollen, and mother is also swollen. And another is a biophysical surveillance by fetal middle cerebral artery peak systolic velocity. And here in this, we chart out, and this chart shows that if it is in A zone, this mild anemia, and if it's coming in the B zone, then there is a moderate to severe anemia. And the middle cerebral artery peak systolic velocities, when it is less than 1.5 MOM, then it's you can take the patient till 37 completed weeks. And if it is more than 1.5 MOM, then if the baby is more than 34 weeks, you deliver. And if it is less than 34, sorry, it is written wrongly, it is again less than 34 weeks, then the fetal blood sampling is done. And if the hematocrit is less than 30%, this is again all the highly specialized centers, perinatology centers, and the fetal medicine, where the proper patients are being taken. And if it is less than 30, hematocrit is less than 30, then we go for the then they take it for intrauterine transfusion. I think at few centers they are doing so nicely, the intrauterine centers. And in Lucknow, Dr. Mandakini Pradhan, I know she has done tremendous. And then fetal medicine, all fetal medicine expert, Dr. Vatsala and all, they made a beautiful video to show. I think we can see over there. And amniocentesis, because there's a sometimes it is needed nowadays, but nowadays it's not been done. And this Lily zone and all, but we should know the name. And this cordocentesis, again, it is done not by all at common hospitals and centers. Again, at a specialized center also, it is very complicated, and risk to the baby is more. So when you are 100% sure that you are going to give the intrauterine blood transfusion, then this cordocentesis should be done. And this intrauterine, a word about intrauterine transfusion is when it is less than 30% hematocrit, and the blood is always O negative, cross mesh with the mother's blood, and tightly packed to achieve hematocrit of 75 to 85%. And route is mainly intravascular and umbilical vein at the cord insertion. And previously they were doing at intraperitoneal. Nowadays it is not done. And this is a picture, very hard, like it needs a great skill to do the intrauterine this transfusion. And a word about the methods of delivery. Sometimes we are worried whether we normal delivery or go for a cesarean. This normal delivery is generally recommended, and there's no harm. And nowadays, because the methogen is not given, and the third stage of the labor has to be done like everywhere. And with the induction of labor can be done with this vaginal prostaglandin gel, and to make the cervix ripe, and you can do the induction with the ARM also. And cesarean section is in case where the baby is premature to and then only it is preferred. Otherwise, in that case only the cesarean is recommended. And precaution which are to be taken in vaginal delivery are very simple. During delivery, just remember not too much of fundal pushing in the second stage of labor, and this methogen we are already avoiding, and because we are giving intramuscular oxytocin, and early cord blood clamping, and no milking, no uterine massage or squeeze in the third stage. Let the placenta to be delivered spontaneously and avoid avulsion of the cord, and try to protect as much as possible the vaginal and the perineal wound or laceration from being exposed to the fetal blood spillage from the cord. Just take a care. And during LSCS also, spontaneous delivery of the placenta using control cord traction, and avoid avulsion of the cord and prevent spillage of the blood from placenta into the peritoneal cavity. And at birth, send the maternal blood for again the antibodies and the fetal red blood cells in the maternal circulation if possible. But generally we don't do this. We only send the cord blood samples and for the direct Coombs test and infant blood group RH typing, infant bilirubin level, and hemoglobin and hematocrit level. And the dose of anti-D depends on the amount of FMH which is being normally, and in private practice this we don't do this Clehorst-Bethke test, etc. because but one thing to remember, the 100 microgram of anti-D neutralizes 4 ml of the feto-maternal blood cell, the hemorrhage which is occurring, and we are already giving quite more than that, because we are giving 300, so it is taking care of the this thing. And one word about this prophylaxis. This is very important. This antenatal prophylaxis is one of the very important thing which we should do to prevent mother from being sensitized. And this prevention is by the screening of all the pregnant women, and to the this RH grouping and antibody screening. And as there's a one famous saying by the Vincent Freda, by saying the rule of thumb should be to administer anti-D immunoglobulin whenever in doubt or about the dosage. It's better to give than to withhold it, and you can give up. It's not going to harm if you give a little higher dose. So just you need not worry. And antenatal prophylaxis, there are in antenatal periods there is only 1 to 2% chances of the silent bleeds, and anti-D prophylaxis is effective for 12 weeks. So if we give injection at the 28 weeks onwards, so that it will cover the this feto-maternal hemorrhage at the time of delivery, and the single dose is preferred. And this all the non-immunized patient, it is given to all, and it has this has decreased the risk from 0.9% to 0.35%. And as the one thing also to remember, as the half-life of this anti-D is 8 weeks. So sometimes when you do at near term, then the patient, you may get this thing. You may get the positive and titer can come positive 1:4 or like that, and you may get confused that patient is developing sensitization. And this indication for this anti-D injection and after miscarriages is to remember all therapeutic termination, all therapeutic, like irregardless of the gestational age or methods, medical or surgical. This is to be not to be confused. So or just we have to remember, so many ask हमने MTP pill दिया तो अब हमें देना है क्या नहीं, हमने DNC किया अब हमें देना है कि नहीं. You have to give. And all surgical evacuation like this DNE and this suction, and threatened abortion after 12 weeks. See, remember this, threatened abortion after 12 weeks. And if you have to give less than 12 weeks if there are heavy or repeated bleedings. If you are suspecting that the fetal-maternal hemorrhage may be high, then you give, or if it is associated with abdominal pain, then we must give, even in the threatened abortion. And in ectopic pregnancy, yes. And in all the conditions where the fetal-maternal hemorrhage chances are there, like all cases of APH, and if there is a fall or closed abdominal trauma is there, uterine death also, one must give. And this invasive prenatal diagnosis, amniocentesis or CVS, after this, one should also give. And it is not indicated if there is a complete spontaneous abortion less than 12 weeks and threatened miscarriages less than 12 weeks, because, or if the cessation of the bleeding is there before 12 weeks. Suppose 8 weeks पर उसको थोड़ा बहुत she bled, and so we can avoid, it is not required. And because the reason being given is unlikely to cause significant fetal-maternal hemorrhages, because it is a maternal immune system which takes care also. Under the postpartum prophylaxis, we already talk about that the 99% of the women have fetal-maternal hemorrhage of less than 4 ml at delivery. And when 500 international unit or 100 milligram will neutralize this. And we are giving 1500 international unit, means 300 microgram, which will take care of the 15 ml of the fetal-maternal hemorrhage, which is quite high. So, and adequate. And it should be given, sometimes there is a confusion in giving for how, at what time we can give. So generally it is advisable to give within 72 hours, but if missed, then it can be given up to 13 days. And it has been suggested sometimes, if, like I have heard somewhere, that you can give even up to 28 weeks. It's better to give, because if they can take care of. If antenatal dose was given less than 3 weeks from delivery, for any sensitizing event, repeat postpartum dose may be avoided unless you think that there may be a large fetal-maternal hemorrhage. And nowadays, a word about the anti-D injection. It is polyclonal we are using nowadays, and the site of injection is intramuscular and deltoid muscle, which is a very appropriate and safe site to maximize absorption. And gluteal region, generally it's not advisable, because it is said that there may be a less absorption. So the deltoid is is preferred. And sensitizing pregnancy, again, take home message for the there are two types of pregnancy: sensitizing pregnancy, like the one where the fetal-maternal occurred and the antibodies developed. It is the first pregnancy, and it is mostly during delivery. And there is first time there is a weak response, and it does not cross. The antibodies formed for the first time are the bigger ones, because this IgM antibodies there, and they do not cross placenta. And first baby is thus not affected, and the fetal effects of the isoimmunization are not all that serious. And when there's a secondary response and the sensitized pregnancy is there, and the Rh positive fetus, then if there is a fetal-maternal hemorrhage occur, then there is a large and huge immunoglobulin response, and this IgG are very small antibodies, and they cross placenta, and they are the main killers for the fetal red cells and outcome worsens with every pregnancy. And last and take home message is, never bother so much, and be confident to all the patients should be well aware that you are Rh negative, but don't just follow the recommendations and all the this fetal-maternal surveillance test, and patient can say very nicely that koi doubt mat rakhna, I can manage negativity. She can tell her family that don't bother, I will manage Rh negative pregnancy very well with my gynecologist. Thank you very much. Thank you, Jabalpur. Thank you so much.
Thank you, madam. Before anybody comments, I just want to know that you have ended the topic of RH negativity with so much
Yeah,
positivity.
medical disorder.
I loved it.
When where there is a Komal, then there is a positivity. And Jabalpur का total too much of positivity. I am, my God, मैं तो खिंची जा रही हूँ.
आप
थैंक यू,
टेलीपोर्ट हो जाओगे.
आपने बहुत ही सिंप्लीफाइड वे में टॉपिक समझाया है. वी आर रियली हैप्पी दैट यू हैव सिंप्लीफाइड ईच एंड एवरीथिंग starting from the first pregnancy up to multiple pregnancies. You have simplified who should receive this dose, who should not receive, what should be the amount, what should be the dose to be received. In the first pregnancy, you don't usually encounter such complications. The complication starts from second pregnancy. You have to get a indirect Coombs test done. If the indirect Coombs test is negative, you don't have to worry. You can give her RH NTD at 28 weeks and then follow her up after delivery. Give her a follow-up dose. And if her indirect Coombs test is positive, then there is no use of giving her NTD. Then you have to follow this pregnancy and monitor the baby very frequently to see how much the baby is getting affected and chart all those levels. The anemia of the baby has to be charted on the release chart, and then accordingly you have to manage that pregnancy. And in case you feel that the level is increasing very fast, you have to refer the patient to a fetal center where the further care can be taken and the transfusion can be given to the baby timely and the baby can be delivered timely. You have explained each and everything very nicely, and I think we should thank you that you have really simplified this topic. During our PG days, this topic used to be a big topic, but nowadays we have seen that RH immunization has decreased so much, and we do not need all these fetal medicine centers very frequently. Very rarely we need them, but we have to be conscious that this thing can happen and you should refer the patient timely. Thank you, madam, for the lovely lecture.
Yeah, Dr. Sangeeta, really ultrasound, this third eye has, and like third arm also you can say, has really saved our life. Matlab, like we are very cool and confident that ultrasoundologist giving us report of ultrasound and Doppler and cool.
Rightly said, madam. We can monitor the pregnancy nicely. We can see whether the baby is getting affected, whether there is hyperplacentosis, whether the hydrops vitalis is occurring, and then accordingly we can take action as per the this.
Namaste, thank you. नमस्ते मैडम, विभा मैडम आपसे स्पेशली अलग से बात करूंगी मैं. डॉक्टर निशा मैडम एंड एवरीबडी एंड डॉक्टर कोमल, थैंक यू वेरी मच. आई एम रियली, इट्स अमेजिंग
So much.
Thank you.
Thank you, madam. Thank you. Archana, madam.
Sana, is there any question? Please check.
Ma'am, as of now, there is only one question.
You could read it out. Can you read it out, please?
Madam was so clear, Archana madam. So I think everybody has more questions because she has explained in a very simplified manner, you know, which can even anybody can understand it so well. So I think.
Now the time for Komal to take the panel.
I'm waiting. Posting it. We'll wait for the question.
May I get the slides of panelists, Sana?
Yes.
Yeah.
So I will answer on the chat.
So a very long-awaited, challenging medical disorders in pregnancy is always a topic which every obstetrician want to hear, because we being gynecologists and obstetrician are little poor in medicine and want to understand what medical people do and what they are going to do. We want to learn, because every time every obstetrician doesn't have a support physician at the moment. So sometime we need to understand that at point of time what we can do easily, and when we need to refer our patient to some physician, endocrinologist or some medical person. So for this we have a wonderful panel discussion, and our moderator is Dr. Komal Chavan, madam. She is already I have madam has introduced. She is medical disorder committee chairperson and director Chavan Maternity and Nursing Home and honorary professor of RN.
I have been introduced, so
Okay,
again,
okay,
you can
fine,
go
ma'am.
to the
No
panel.
issues. I have been worked with ma'am as well, and with sir also. I'm really obliged by madam's Ganesh festival celebration at her home. I enjoyed really at her home. Thank you so much, ma'am. And now I would like to introduce all our panelists one by one. We do have physician, internal medicine specialist, Dr. Aditya Parihar, who is MBBS MD from Gajraraja Medical College, Gwalior, and a very active API person. And he has done his DMSc in Advanced Diabetes from Birmingham University and has professional experience of 4 years and working as consultant in Marble City and Manulal and Allergy Clinic.
दे दो ना कोई दिक्कत दे दो.
Next, please. Our second panelist is Dr. Devesh Kumar Gupta, a very enthusiastic and active anesthesiologist and internal medicine person who is with us. He is consultant at JHNCH, has been consultant at JNCH Bhopal and presently working in City Hospital. He has a special interest in USG guided procedure in OTs, and also he go through for epidural analgesias for labor. He is joint secretary, or he is presently joint secretary of ISA, Jabalpur Society. Our very senior obstetrician, Dr. Manik Panse, madam. She is director, Anand Hospital, and she is always dealing with high risk pregnancy as well as colposcopy and cancer screening. Dr. Nidhi Jain, our vice president 2020. She is consultant gynecologist and laparoscopic surgeon at Muskan Clinic and has worked in various places, and her special interest is in vaginal surgeries and ultrasound and USG. She has many papers in her credit and award of Government of MP for good work in PMSMA 2019 and Femina Award by Mind Group Pride and Evident 2019. Dr. Roma Sonkar, our treasurer since 2 years, and she is gynecologist in various places. She is also member of Foxy, CELSI, IMA and MSc, and papers in her credit also. We have endocrinologist Dr. Ashish S. Jingra sir, who is MD Diploma Diabetes, FISCM Fellow Diabetes from Mumbai, and in thyroid and obesity specialist. He is director of Mahi Diabetes Thyroid Care and Research Center, and one of the very active endocrinologist from the city who is every time busy in organizing many of the national and international level conferences for Jabalpur like place, which we presume that it is small, but when sir organizes the conferences, then we realize that we are in national and international platform. So presently sir is organizing secretary of Jabalpur Diabetes update and Jabalpur Thyroid update and MMRF insulin workshop. He has been past vice president of API chapter Jabalpur and presently president of Jabalpur Endocrine Society as well. So welcome all the panelists, and over to Komal ma'am.
Thank you so much, Dr. Kaveri. I do remember you very well when you were studying in Mumbai, and so nice to see you as a secretary of Jabalpur and doing really good work with Dr. Anuradha and all the seniors who are guiding you. So, my job is to now conduct a panel which is so Why it is not happening? Yeah, I'll just restart my presentation again. Yeah, it started. It is not moving. Just okay. So it is now my job as now to have a panel on challenging medical disorders in pregnancy is a very easy job because the Jabalpur Society, everybody has now roped in all eminent panelists. So we have with us right from endocrinologists to intensivists, physicians, and senior gynecologists. And medical disorders in pregnancy are always increasing, or we see so many underlying medical disorders. And why are we worried? I want to know from a gynac panelist, are we seeing more amount of medical disorders in pregnancy? Dr. Manik, you
Yes,
can take this question.
because I'm a very senior person working in
Yeah.
Jabalpur since last 30 years. I did my post graduation way back in 85. Okay, this topic was a very small thing. We always used to give a call to the physician in medical college, and they used to come and do they used to help. But now it is around 15 to 20% of all pregnancies that we have medical disorders. The causes are nowadays we think that no woman should die of pregnancy or childbirth or due to any medical disorder or any obstetric cause. The incidences are increasing because people are coming for preconceptional counseling. They are reaching the age of pregnancy because their childhood problems are being treated earlier. There are more cases of PCOS due to changing lifestyle. Obesity is on rise. Better diagnostic facilities are there, and girls are educated. They are doing job. They first want to settle, and then they go for pregnancy. When we do preconception counseling, there is proper history taken. Many times we come out with problems which were otherwise undiagnosed. We come to know that the person is taking alcohol or smoking or any drugs, or if there is any history of taking anti-epileptic drugs or any sort of medicine, whether she is diabetic. So this is how I think more and more cases are coming with medical disorders. Many times pregnancy itself tells us that she had some underlying VSD or something of that sort, which was healed by a membrane, and pregnancy causes trouble. Then AV malformations of the brain, they are usually undiagnosed. If they are diagnosed, then it is always better to treat them pehle, and then she should go for
Yes.
pregnancy. That is my way of thinking. I
You're
think
very rightly said, because there is an effect of pregnancy on the medical disorder, and the disease also causes effect on the pregnancy. So both way
now
we see
we
lot
have
of
multi disciplinary approach. हम लोग साथ में हैं, अकेले नहीं हैं डिलीवरी के लिए.
हाँ.
चलिए.
So now in brief, Dr. Nidhi, can you just summarize the effect of pregnancy on of this disease on pregnancy, both mother and the fetus? How different a pregnancy with a medical disorder, how differently you would be managing than a normal pregnancy?
Yeah, as Madam rightly said, that many diseases are on rise, like hypertension, diabetes, thyroid disorders. Many medical problems are increasing day by day, and mother's age is also increasing. So all these have deleterious effect on mother and fetus also, and we are having facing challenging situations like early miscarriages, preterm births, intrauterine growth restrictions, and like postpartum hemorrhages and many other complications we are seeing on higher side as compared to the normal pregnancy. So definitely all these diseases have deleterious effect on the mother as well as on the fetus.
So we know we are seeing more amount of diabetes and lifestyle very well
Yeah,
said by
yeah.
Dr. Manik, and these are the innumerous medical disorder very nicely summed. The things in the red are usually the commoner ones. So we do encounter into our day-to-day practice. So my plan was, as pregnancy, the age and all, it is increased, all the medical disorders. What happened in normal pregnancy, there is an underlying medical disorders, and sometimes these medical disorders itself make a pregnancy as a high risk. But we sometimes have a challenging situations. So medical disorder itself is a challenge, but there are some challenging or common critical nightmare situation encounter. So I don't want to tell a detailed history, but some bad or some memorable, some case which you have managed, and what was the underlying medical disorder? If you can just tell in a line.
Madam,
Dr. Manik, we start with you.
yes, I would like to tell you there was a case. She got married 5 years back. She was not conceiving. We came to know that she was a case of PCOS. Then her husband had oligospermia. Somehow she conceived. Up to 6 months, everything was all right. We just gave her this Eltroxin 12.5. That is the only thing which I gave. She had delayed conception. It's okay. Then she had one one bout of I should say acute febrile illness at 28 weeks. She was admitted with me. The fever came down. We gave her PMOL infusion. We had to give her PMOL infusion. We sent her all the investigations, all possible, because that time dengue was rampant. The thing I'm narrating is 2 years back. But suddenly she said, my baby is not moving at 12 o'clock. We got her immediate ultrasound. My staff did not allow her to go home. That was the only good thing probably was done. And sonography showed a huge retroplacental clot, and he literally collapsed. 90, 60, 80, 60. मेरे सामने उसका BP जा रहा था. Somehow at 3 o'clock we did a section. I called a surgeon. There was cochlear uterus, and you can imagine उतनी रात को ओटी के टेबल के नीचे वो cochlear uterus देख के हमारी तो जान चली गई. और उसके बाद में बच्चा निकाला, the baby was dead. उसके बाद में उसको आईसीयू में शिफ्ट किया. शी हैड वेरी small amount of urine. We called a nephrologist. Nephrologist shifted her by evening. उसका एक डायलिसिस भी हो गया क्योंकि acute renal failure is very common. It is pre-renal. 8 दिन के बाद में सब कुछ ठीक हुआ. I don't know. She was in some hospital where facilities were better than my hospital. और वहाँ पे उसको एक सबक्लेवियन डाला और उसमें उसको सडनली एक हीमोथोरैक्स हो गया एंड शी अगेन कोलैप्स्ड. उसका सीटी किया. उसका ये मेरे को बाद में पता चला एंड देयर वाज अ बिग हीमोथोरैक्स. उसमें इंटेंसिविस्ट ने बाद में और कार्डियोलॉजिस्ट ने मिलके वो सारा निकाला और इस तरह उसको बचाया और वो हॉस्पिटल से 44th डे वो डिस्चार्ज हुई. मतलब ये एक जो कॉम्प्लिकेशन थी मैंने तो अपनी 40 साल की प्रैक्टिस में कभी नहीं देखी थी. मेरे ख्याल में हमारे वक्त में वो पेशेंट तो वहीं 48 घंटे के बाद मर जाती.
So unfortunately, you could save the patient. Unfortunately, we lost but maternal mortality is very important that you could save the patient. That was a big challenge, and you have seen almost all the cases actually. Like what are the challenging cases or what are the critical cases which I have actually shortlisted to discuss in today's panel. You have encountered all that in your one case. Yes. So without that, now we'll go to our case. And now this patient is a 21-year-old unregistered with a BMI of 16.9. She's a second gravida. And at 38 weeks, she's come with history of vaginal leaks since one day and feeling of unwell, vomiting, and also mild abdominal pain. She had a past obstetric delivery was a one delivery a year ago. And now on examination, her temperature is high. She has tachycardia, pulse is 100, heart rate is 112. her saturation looks okay. On examination, uterus is full term, vertex, FHS fetal heart sound look okay, but on per speculum examination, there is hot vagina, minimal yellowish discharge, and she is just in labor with cervix, one finger loose, 50% effaced, but membranes are absent. So clinically, seeing her condition, and then we got her hemoglobin done. It was 3.7 with blood picture showing folliculocytosis and multiple reactive lymphocytes and the probable. So Dr. Roma, we go to Dr. Roma. When you are an obstetrician and you're seeing such patient, what actually comes into your mind when you see the history of such patients, and what must be the cause of that anemia? Actually, she has got this severe anemia, but what do you think is the cause of that severe anemia in this patient? Dr. Roma, is Dr. Roma there?
Hello.
Hello, yeah.
Yeah, ma'am, as patient nutritional status is very poor, her BMI is less, so she is malnourished. The most important, she is a case of nutritional anemia. And during antenatal period, she is already anemic. So at the last, her hemoglobin is 3.7. Um, Maybe she has not taken proper antenatal care. She has not taken iron folic acid tablet.
She's unregistered.
She is unbooked patient. She has not taken antenatal visit.
So probably even she had a delivery a year ago. So it is too soon. There is no spacing. There is no contraception use. Or these are the causes which a patient may be having some underlying infection or improper diet. Or she may be anemic to begin with because she has just become 3.7 without any obvious bleeding. So definitely this patient, the hemoglobin count was not properly taken care during her antenatal period. And when are we discussing? We are discussing anemia. I have chosen this case because this month happened to be the iron deficiency awareness month, and 26th of November is the World Iron Deficiency Day. And Foxy Medical Disorders and Pregnancy Committee, we are planning to have a mass campaign to make every pregnancy anemia free. So we should not see such patients coming at a complicated state with a hemoglobin of 3.7, and because of the hemoglobin now, what do we suspect? She's having a fever and little hot vagina. So what are we aiming? What is our clinical thing? What
Ma'am,
are we thinking in our mind?
Ma'am, she is a case of severe anemia with premature rupture of membrane with a sign of chorioamnitis.
Yes, yes, we are thinking on the lines of chorioamnitis. So what would be your urgent priorities in the care? What would you do to this patient?
Ma'am, immediately we have to admit the patient. Patient require intensive care, ICU management. We have to arrange packed cells around 3 to 4 units, and we have to give triple antibiotics. Higher antibiotics should be administered to the patient. Fluid overload should be avoided.
Yes.
And after, if patient is stable, then we have to decide the mode of delivery.
Yes, we will come back to the delivery. Now we are admitting her in an ICU. So I will come to our intensivist counterpart, Dr. Devesh. So what would be the urgent priorities? How do we stabilize such a patient? Because she is in labor, a delivery may be imminent. So our first priority is to stabilize her so that we make the delivery more comfortable. So what preparations and what are the urgent priorities?
Yeah, in any case, like other than the pregnancy or in the pregnancy, the protocol of critical care is almost similar. Like in this case, if you go from the previous slide, I can find out some critical moments, critical evidence in this history, like the BMI is low. Okay, so this may leads to the anemia, and because of these kind, this patient is very prone for the infection and later on the sepsis. As the patient also, you in the history you say there is a chorioamnitis also, and if you see the investigation, the patient is already in the impending sepsis line. So the priority right now, the priority is to correct the anemia to deal with the infection part also. So, and after that, we can plan, we can discuss with the obstetrician okay, what is the urgency and how we can delay the delivery part of this patient. So I can get time for the stabilization. So the priority is correct the anemia, to intervene the infection, to find out the any impending sign of shock or the myocardial any event, because this patient is also prone for the myocardial infarction or the CCF and the fluid overload. If we give whole blood or if we correct anemia very correctly, very sorry in
Very
very
fast
short,
correction.
very fast
Yeah.
correction. If you do very fast correction, this patient may land up in the CCF or in the pulmonary edema. So the correction is required, but not at the cost of uh,
How
derangement.
many kinds of transfusion would you transfuse on a first time when you're seeing the patient? That
Yeah,
many
if you see that,
pack cells would you arrange?
yeah, uh, the correction of anemia in the previous era. If you talk about the era of previously 1980, we generally use the liberal uh, blood uh, transfusion. But after that, we come to the restricted transfusion. Still, the goal is to achieve at least the 7 gram per deciliter of hemoglobin, and after that, we can restrict the blood transfusion. And as we know that the choice of the blood transfusion in this case is the packed red blood cell, not the whole blood. Okay. And if we give the packed red blood cell, which is fresh less than 15 days, it will increase the hemoglobin by 1 gram per deciliter or the hematocrit by 3%. So according to that, we have to transfuse at least 3 points before going to for the delivery, and then we can reserve 1 or 2 points uh, for the procedures also.
So definitely the blood transfusion of blood control of infection is the most important. Now the patient has been stabilized and controlled. Dr. Manik, can you just throw a light? What would be a preferred mode of delivery and what care as an obstetrician you would take? You definitely have an intensivist and everybody to guide you, but as an obstetrician, what precautions you would take during her delivery?
Well, she might bleed also after delivery more. So will cut down her delivery period as early as possible. We should deliver her because it
Because
is
there is a chorioamnionitis,
yes,
probably. We
choreo.
need to deliver her.
Yes, and if not possible, we can even think of cesarean also in her case. There is no harm, and baby should be shifted to an ICU. And because in anemia they have uterine inertia also, many a times they have dysfunction labor, then there are chances of cardiac event. And though we have corrected her anemia, but she might not withstand PPH afterwards, so we should
So
have,
we would keep everything ready for the anticipating PPF. So that is really very
which is
important.
very important.
Yes, very rightly said.
Hmm.
I just wanted to know from Dr. Aditya, what about injection Lasix? Do we give post-delivery Lasix to this patient empirically, or is it required?
Actually, the hemoglobin level is very low, and it itself causes dilutional status of the mother. So we have to deal. We have to look for the peripheral signs of this collection, third space collection, and if third space is collection is considerable, then we can give Lasix either infusion or in a bolus cases. And the history itself is throwing various points, and it is has to be prioritized. We have to consider the sepsis part first, and anemia has to be corrected accordingly. With this protocol of infusing packed RBCs, we are in less chances of increasing this dilutional state. So yes, Lasix can be given, and it has to be decided according to the clinical signs what we are seeing in the patient.
What about? I just want to know. This is out of like in Jabalpur. Do you always get Paxils or all the government hospital giving whole blood? What is the
Ma'am,
scenario there?
actually, in nowadays, in these current scenario, it is advised that PECT cells should component therapy should be advised, because what happens in component therapy is that we are preserving the other parts. Like if we are giving this packed RBCs, then platelets are reserved for other persons. So in government institution, it will be more beneficial. So we should encourage this component therapy much more, and it is a good uh, follow that we have to be following guideline according to the guidelines.
Okay, thank you. So anyway, this is the Foxy classification, and we know that anemia is what we say is a trimester-wise classification in pregnancy. If it's first trimester, it is normal is 11 or higher, and anything below 11 will be mild. Then moderate would be between 7 to 10, and less than 7 is the severe anemia, and that also correlates very well with the ICMR classification, which we still follow, but less than 4 becomes a very severe anemia. So this patient which we were dealing was a case of very severe anemia, and we need to take utmost care as described by our esteemed panelists. And blood transfusion, I think, very nicely said about the 7 gram, which all covered, and usually RCOG, and everywhere I think we do take consent for the blood transfusion. So with that, we will we had touched upon the anemia case. Now we come to our second case. This is a 35-year-old, Gravida 3 Para 1 living one, previous 1 LSES, 10 years back at 35 weeks. Now she is twin gestation and conceived after 3 cycles of ovulation induction, and there is it's a cervical circlage done. And now she has a history of high grade fever, body ache since 2 days, also difficulty in breathing, and there is no history of pain in abdomen, no leaking, no bleeding. And she had a 10-year-old female child, 2.5 kg, doing well. Followed that, she had a spontaneous abortion. There is no other significant past history. And on examination, she has mild pedal edema, breast thyroid is normal, blood pressure is 140 by 100. So, what comes into our mind? What is our provisional diagnosis? So, Dr. Nidhi, can you just
She's having fever since 2 days.
Mhm.
Uh, Fever since 2 days, and mm,
We have examined, she's come to you, and now we know that patient has is having a fever and probably something we got
yeah,
on our clinical history.
yeah. So she's actually how much week? 35 weeks
35
pregnancy.
weeks, and when we got the
35 weeks
investigation
pregnancy with
done,
body ache and fever with chills since 2 days. So I will suspect any febrile illness
yeah,
with her, and I will do the investigations according to that.
yeah. So you have
She is
done the investigation. This is a picture
yeah,
of the.
moderately. Yeah, okay. Her
So on
hemoglobin is 7.4 and bilirubin is 2.1 and dengue NS1 is positive. Okay. So she is a case of dengue fever and maybe possible the liver function tests which are deranged may be due to the dengue fever. So
and also the blood pressure which we
yeah,
got.
blood pressure is also high and mild pedal edema. So preeclampsia with dengue fever.
Do you think it could be HELP syndrome?
But dengue NS1 is positive, so I will
So
not.
dengue can be an added feature, means
Yeah.
kind of.
So
What about
it is
Dr.
not
Manik?
HELP syndrome, but it is dengue fever.
What Dr. Manik, what do you think? Like the liver bilirubin is high. She is definitely having a high blood pressure, so and low platelet. So do you think it could be HELP, or you feel it is a dengue? What is your take on it?
I think urine routine should be done. It is not
Yes.
there. Urine routine is
It is not mentioned here.
not there.
Probably it was done. Yes.
Uh, So
Yes, madam.
Platelets are also on the normal side. So HELP syndrome.
22,000.
22,000 platelet. The lower side, na madam.
Okay, 22,000.
Probably because we have a report of dengue, we rely on dengue. But clinically, we can keep a HELP in our mind too. So that was the hint. So, do you? What are the common things? Like you said, you had a patient of dengue. How would a patient of dengue usually would present? How do you diagnose a case of dengue? By titer, or because the titer will not come positive immediately.
Yeah.
There is a time. I think Dr. Aditya can throw a light on that. When is the ideally we should get a dengue NS1 test done?
Actually, there is a line with this period of time in which particular test comes positive. Considering this dengue, the NS1 antigen which comes positive is from day 1 to up to day 5. So it depends upon which time the blood is extracted for the investigation. This IgM antibodies starts from 5th day and it persists up to 8th day, and IgG antibody starts coming from 7th day onwards, and it persists for a longer time, for more than 3 months. So it depends upon the stage of the disease, the dengue disease. Initially, if we are in a dilemma that it can be dengue, we can go for NS1 antigen, which shows that active stage of dengue is there. Hello, I'm audible enough for you.
Yeah, you're not.
Right.
So this is the guideline that NS1 antigen comes positive from day 1, and it remains up to day 5. IgM antibody starts appearing from day 5 and it persists up to 10 to 14 days, and this IgG antibodies starts after 10 days and persists up to 3 to 6 months.
Yes, yes. So definitely, when in absence of the NS1 test, we do rely on the signs that the presence of nausea, vomiting, if there is any rash, to indicate test positive. If a WBC it is showing a leukopenia or a low platelet, we will definitely suspect a dengue. A CBC report is quite evident, and these are the warning signs that if there is any bleed or something or liver enlargement, then we know that we are managing a case of dengue fever with complications. Medical complications, definitely we know all these can be medical complications, but what I'm me worried about the obstetric complication. That if dengue is affected our patient, we if she is not a full term, there can be a preterm birth, low birth weight, antepartum postpartum hemorrhage. Dr. Manik, your patient had it with dengue. She had a antepartum hemorrhage, retroplacental clot, and fetal
Yeah.
distress, and intrauterine death. So these are the complications which we are always scared of when we are managing such patients. So now coming to this, Dr. Manik, I know you had admitted the patient, and this patient is 35 weeks. So you have admitted it under your care. Would you give steroids to this patient?
I did not get time to give steroids, but if
No,
she
not to
settles
your
down
case.
with
This
the
case.
conservative line, then we should give steroid. If she settles down with conservative line of treatment, then steroid should be given.
So, what would be a preferred route? I just want to bring at a point because the platelet count is 22,000. So, is it okay, Dr. Devesh, to give her steroids when the platelet count is 22,000?
Yeah,
Where we
No.
start lung maturity. But usually, our dose of prophylactic steroid is an IM dose. So, you can clarify the picture.
Yeah, if you are talking about the treatment of dengue in view of steroid, so in for the dengue treatment or there is no role of steroid in the dengue treatment. Only the role of came when there is a dengue encephalitis is there. So, like in this case, the platelet count is 22,000. I would like to know other the liver profile and other investigation also.
Liver profile also was little on the higher side.
No, if it is on higher side, because in dengue there are three phases. As everybody know about the dengue, that's the febrile phase of 2 to 5 days, and then the critical phase is appear when there is a warning sign is also the leakage, the plasma leakage is there. So if there is a leakage, you can titrate, you can actually calculate this leakage in terms of platelet counts also. When it is started, the platelet count is coming down from the 50,000 to 1 lakh approximately. When it is almost 24 hours, it comes down to below 15%. At the same time, you have to follow the hematocrit level also. But in pregnancy, definitely the criteria is not as absolute as in the non-pregnant patient, but still, because this patient deteriorate very rapidly, the physiological compensation in pregnancy has both the edges. It protects the patient from the many other stresses, but at the same time, it shows symptoms very late. If there is suppose this patient has dengue in the second phase and there is a lots of leakage, but still in the initial phase it's very difficult to identify the pleural effusion or ascites or any other sign of plasma leakage until it is too the large amount is already in the extravascular space. So this patient is admitted, and secondly, the single value of any kind of investigation like platelet or any other is not so very helpful. You need to follow the investigation pattern,
Yes.
whether it is the decreasing trend or the increasing trend. This will actually guide you what you are dealing with and how will you treat this patient. So this is my uh,
Yes. So I think you have explained very well all the phases of dengue and how the monitoring has to be done and everything. So for the lung maturity, what we are worried, like probably we would consider giving a load of steroid that doesn't affect the platelet count, and usually we can give. It's the only indication where we can consider giving IV steroid than our routine IM steroid because the platelet counts are low. Now coming to that, Dr. Nidhi, can you tell when do we will you cut the cervical stitch? Because now patient is already 35 weeks, she's calm, she has already dengue. So what about the cervical stitch? Do you want to touch that cervical stitch? She's a previous LSES with twins. Dr. Didi or Dr. Roma, anybody can answer.
Ma'am, we will wait up to 37 weeks, then we will cut this cervical stitch.
Yes. So you would wait, you will not touch the stitch right now. What would be your mode? And if the patient goes in labor, then you would cut.
As patient is previous section, then I will go for LSCS. I will plan LSCS.
With platelet count of 22,000, with bilirubin high, she would not be a candidate for spinal. Will we be anticipating complications with a general anesthesia? So, would you like straight away go for section, or you would do some preparations prior to that? Dr. Nidhi, you can take it. I can't hear you.
Yes, ma'am. I have unmuted myself. Madam, at present she is in critical phase. So I would like to wait for the period to be over.
Yes.
And when her platelets will be on higher side increasing and her packed cell volume will be decreasing and everything will be normal, then only we will intervene. And
Yes.
then only we will think of removing cervical stitches or the delivery point of view.
Yes, so this was a real case. Actually, this was a real case which I managed, and we did the same. We actually wanted this patient, that patient, to improve, so that we give all our treatment therapy with the multidisciplinary approach, with the intensivist, with the medical team. And she was a case of dengue hepatitis. So it was not a HELP syndrome, and we waited. Then when the patient to improve her platelet count to improve, and then only the ideal thing is to cut the cervical stitch. At one moment, even I thought, if the first baby, there are some Syrian gynecologists who would also say that if the baby weight is small and the first baby happens to be vertex, they even were in favor of giving her a trial, like not a sure shot cesarean section. If you have a facility of ICU and a critical operative center or whatever to deal with the complication post anesthesia, you can give her a safe delivery by means of a cesarean section. But even giving her a trial under close monitoring was also not a bad option. So that can be considered in this case.
I mean, if something would have gone wrong to the babies, then we would have thought of cutting the stitches and
Yes.
allowing these to
Yes.
deliver. Otherwise, अपने आप से तो I would not interfere at this stage.
So we are happy that the patient is managed by our medical and the intensive and ICU counterparts. And when our role comes, we will go. But what happens is that the trick is that when the patient has fever, she goes in labor.
Yes.
So invariably, it happens. Everything happens together. And same, my patient also went in labor. We did a section for, but our plan of action was that, and the dengue has its own course, as very rightly said, that when we have a patient of dengue, the critical, that is the febrile phase, is 1 to 4 days. Then the critical phase starts from 3 to 6 days, and then is the 7 to 10 is a recovery phase. So if we go past through that critical phase and go to the recovery phase, patient platelet count will automatically start increasing. So we don't have to do much. So we have to pull on that much time. So that is our basic plan in this dengue. So if we don't touch, we are safe. If we intervene, we will have problem. But if a patient goes in labor, we are left with no choice.
Yes.
And these are the FOXY guidelines for management of dengue, and to know that how we need to give the fluid, to know how is the BP of the patient maintained. We need to know that a saline is a common thing which is given 5 to 10 ml per kg in an hour. If there is improvement, then you can reduce it to 5 to 7 or 3 to 5 ml, and we need to keep the patient under monitoring. But if it is not, even a bolus 2 ml of normal saline 10 to 20 ml per kg is recommended. And with that, if there is no clinical improvement and a patient is severely pallor or any overt sign of any bleeding or anything, then those patients would require urgent blood transfusion. And as very rightly said by Dr. Devesh, that you need to keep your hematocrit level always monitored every time. It's not a single reading what we rely on, but it is a serial reports what we do on daily basis. And we have discussed all this. So now coming to the third case, this patient is now, because I know that all panelists have contributed, and we have our very senior endocrinologist friend who is very popular in Jabalpur. So we nearly need to know a certain, and as he is doing so much work in thyroid, I have added this thyroid case. This is not a complicated case, but when thyroid is simple, but it can really be challenging to manage a case of thyroid. So this patient is a 28-year-old primary with 12 weeks. She's come for a routine antenatal checkup, and everything ANC profile and everything what we do is normal, but her TSH is 4.5. So Dr. Ashish, uh, should we screen
Yeah.
every pregnant woman? What is your take on it? Like, should we screen every pregnant woman for thyroid dysfunction, or should the screening be risk based or universal? What is it like? As we are recommending, as we gynecologists recommend that every patient we do a TSH. But what are the recommendations from our
See,
endocrinologists?
the recommendations are different for different by the different societies like American Thyroid Society, European Society. They recommend for high risk, but the Indian Thyroid Society, they say for monitoring the screening the every patient who is coming to your clinic, because nowadays the incidence and prevalence of hypothyroidism we are seeing in our pregnant females, it is increasing day by day. And as we know, the babies are very precious, the patients are coming with infertility treatment. So in India, the guideline is screen all the females coming to your clinic with the TSH. If the TSH is in first trimester more than 2.5, treat her. In the second trimester, it is more than 3, and you have to treat her. So simple guideline you have to follow: 2.5, 3, and in the last trimester again 3. This is the target.
So definitely now this patient has come with a TSH report of 4.5. So what
Yeah.
would be your first line of action? What would you be relying only on TSH, or how important it is to get T3 and T4 levels, and any you could throw light about the TPO antibodies?
See, the TPO antibody definitely they helps us if the patients are having recurrent pregnancy losses, miscarriages, or there is chances of infertility. Then we should go definitely for that also. But if we are seeing this patient with TSH of more than 4, we have to start her on this in the second trimester. Also, we recommend the target of 3. We will start her with the low dose of thyroxine as per her body weight. And when to evaluate, prior to conception, definitely what is your next question is that how we should proceed. Definitely, if the patient is planning pregnancy and coming to you prior to conception, and our gynecologists in Jabalpur are doing very well in screening of diabetes and thyroid, as I am seeing the cases. So we have to evaluate them prior to conception, definitely for by GTT or by the thyroid functions. And if we are doing it prior conception, you have to keep the target what I have told you, 2.5 and 3. And immediately after pregnancy, if it is confirmed, then we have to act very fast. And with the higher dosages, we have to control the TSH in the first trimester. And at the beginning of second and third trimester, again, we have to control it, but the problem or complications are less because the problems with hypothyroidism or thyrotoxicosis are more in the first trimester. And one thing I want to highlight with the in the line of the thyroid function test, we can see erroneous or false suppression of TSH in the first trimester, which we see due to the HCG changes. So we have to see that free T3, free T4 and TSH in the first trimester if the TSH is going very low. So you have to monitor T3, T4 also, that is also free T3 and free T4 if the patient is having the TSH levels less than the normal values.
Yes, so that is because the physiological changes of pregnancy with the thyroid function, they have so much correlation that we need to correlate every trimester wise, and you have said it very well. And what about the TPO? You have said only when there is a history of any miscarriage or any special condition.
TPO is very important part whether to start the treatment or not in the non-pregnant females also. But in the pregnant females, if we are having the TSH above the borderline, what is the recommendation? If the TPO is there, we have to act very vigilantly in these patients because there can be miscarriages. So we have to follow up them very regularly, these patients. And before pregnancy, if the TPO is positive and the TSH is more than 4 or more than 5, and if the patient is willing for pregnancy, then again we have to treat them before the conception.
The TPO is like in cases of subclinical hypothyroidism or a pre-pregnancy, we need to consider doing a TPO before they plan a pregnancy.
Yeah, if there is history of any recurrent miscarriages or that, otherwise routinely TPO is not recommended. But if there is confusion that why there is definitely recurrent pregnancy loss and TSH is coming in the borderline, then TPO can help us in starting of treatment in the non-pregnant females.
What about the dose? What clinically what dose of
they recommend the higher dosages, that is 30% higher dosages is required before the preconception dose. Suppose the patient was taking 100 microgram, then at the time of pregnancy we have to increase the dose by 30 to 50%. That depends upon the patient's TSH values.
And usually what we tell is to take 2 extra doses in a week, like they're taking daily.
Till the reports are coming, you increase your dose by 2 tablets extra if the patient is diagnosed as a pregnancy positive, and we tell them to start with the 2 extra doses per week if the patient is not able to get the reports done.
Yes. So this is very important because dose adjustment is something which is a dilemma to gynecologists. And when we follow this, what about the postnatal period? Do they come back to the previous pre-pregnancy dose, or do we have to still give them the pregnancy dose? How much time we need to wait for that?
This is a very important question you have raised, Dr. Komal, and this is a very common thing that we see the hyper patients coming, the hypo patients going into hyperthyroidism due to the continuation of the pre-pregnancy dosages. So you and us, we have to tell them, because patient doesn't comes after, they come after 3 to 4 months of delivery. So it is the duty of gynecologist and endocrinologist that in the last visit we have to counsel them. The moment the baby is out, you have to decrease the dose to your pre-pregnancy dose. So this is the message we should give them to before discharge.
So that is really very important about the post. Dr. Manik, I just want to come to you. What about the newborn testing? Is the newborn testing being done very routinely?
Our pediatrician is getting it done on after 48 hours. I just wanted to ask Dr. Ashish Denga what should be done. What should be done? Is it to get it done after 48 hours, or we should take cord blood? What we
Madam, cord blood is the best test, but if we are not able to do it, check it after 72 hours at least, because of the TSH surge from the mother. There can be false or fallacious hypothyroidism will be diagnosed in the newborns. So it is better to do by cord blood from the baby side, or after 72 hours we can do it.
So you all are following routine, because I think it is recommended in few that definitely the thyroid in the newborn screening should be a must nowadays. So I still it's not given in the universal guidelines, but I think all state obstetrician and all policymakers everywhere, they are suggesting that routine screening, newborn screening, at least TSH is really very important. What about your doctor? Yeah, Dr. Roma, you want to say something about newborn screening? Is it done?
FLSC thyroid.
Uh,
Dr. Denga, does it make any difference if we do at 48 hours, after 48 hours?
Yeah, if we do it early, the fallaciously high TSH will be seen because of the surge from the mother. So please, the best is to do after 7 days, but they don't come back after the discharge. So we have to do it after 72 hours, or cord blood is the ideal.
Actually, I
Cord
just
blood, after that, we will have to actually take the newborn blood sample because 72 hours would be the most appropriate time to get it done.
Yeah.
Thank you. I think that is a dilemmatic because thyroid.
is from you.
Yeah. So and thyroid doesn't come with a lot of complication, but treating a thyroid patient, sometimes we see a deranged thyroid, TSH and all levels, and really there is a confusion that whether to treat. Patients also feel that I have a thyroid and they are worried about the complications. So it is a simple thing, but we need to take the message from our endocrinologist friend and treat a thyroid patient. And we should be confident enough, and at least a one reference to endocrinologist during pregnancy would make a difference. So coming to the fourth case, we are coming to the end of the panel. This is a 25-year-old lady. She's again IVF twins. Complains of severe itching in the fifth month of pregnancy, and also itching during her first pregnancy. She had itching. Her fetus died in utero in the third trimester. There is no history of toxemia. Her bilirubin level is zero point 0.8, but there is a raise of alkaline phosphatase, ALT, AST. Even INR is 1.7, GGT is 35, bile acid is also 6 times more. And what is the differential diagnosis? We come to our medical doctor Aditya.
Arya.
Dr. Aditya, you can unmute yourself. Yeah.
Can you show me these lab parameters again, because I was not able to focus on them. Severe itching is.
She's come with itching mainly, and this is
Yes,
a common.
so this is a case of acute hepatitis, because there is more than 3-fold increase in this alkaline phosphatase, SGPT, and SGOT levels. So we have to see for acute hepatitis causes, which can be hepatitis E, which is more common in females. And sepsis can self-induce this hepatitis cause of is one of the cause of hepatitis, but there is no toxemic features as shown in your history.
We will definitely do the markers, the viral markers to rule out hepatitis. And definitely the serological testing was done. The viral hepatitis was excluded, and there was absence of any pain or fever or anything. So infection also was ruled out. But patient had a history of itching with the fetal loss earlier. So we thought probably it was intrahepatic cholestasis of pregnancy. So that was a diagnosis because of itching and a fetal loss. So when there is a history of itching or a sudden IUFD in the third trimester, we keep in mind the history of intrahepatic cholestasis. So how common is, Dr. Aditya, intrahepatic cholestasis, and how do we know about these liver disorders in pregnancy? We see very commonly that or only cholestasis is seen. What are the other liver disorders?
Ma'am, as you are saying that, what are the signs you are saying?
Commonly what you see in your practice, how the like a patient coming with jaundice or a deranged LFT, because what happens when we gynacs see a LFT report deranged, we get really panicky and worried. We will see what we should keep in mind, like that is what our question.
Cholestatic jaundice is there. There are more chances of cholestatic jaundice in this pregnant females. Apart from these, we have to look for these viral markers, because hepatitis can be a common cause in pregnant females of hepatitis. Apart from these tropical diseases like malaria, dengue, these all contribute to increasing SGPT, SGOT levels. But what we have to keep in mind is, in particularly LFT, we have to see 3 to 4 rise in SGPT and SGOT. On concurrently, we have to see for bilirubin levels, whether direct is raised or indirect. If direct is raised, we can look for obstructive causes, and if indirect bilirubin is raised, then we will look for non-obstructive, like this infectious causes or autoimmune diseases. These all diseases we have to look for.
Yes. So we need to not think that definitely that patient may be having a severe form, but we have to go from seeing the commoner indication to the less common. And definitely when we know that this is a classification of the American College of Gastroenterology, where they have said that that gestational age of patient is a best guide. So if it is a first trimester, probably the patient is having a hyperemesis gravidarum. So you can treat that first. In second and third trimester, cholestasis of pregnancy is most common. HELP is in the second half of pregnancy, but acute fatty liver and preeclampsia usually in the third trimester, and they would come with some other parameters also. So we need to know the trimester guide and need to know whether it is we are leading to cholestasis or more severe form, because any liver alteration in liver enzyme need evaluation. We can't just think about cholestasis and treat cholestasis and then it turns out something else. Dr. Manik, you have such a big practice all the time, so you must have seen many cases of cholestasis of pregnancy. What is your common concern about these patients of cholestasis of pregnancy?
They have lot of itching, madam. They come with itching. They cannot sleep in the night. And if you ask them, they have similar problem in previous pregnancies also. And they have a sister or someone having the same problem. That is usually history is often. And madam, we start with UD leave.
Yes. I think that is the only drug I think which everybody is talking. And there are certain conditions where we will actually think, like as it is patient is in third trimester, with twin pregnancy it is more
It
commoner,
is very
with
common.
progesterone use, like they're
Nowadays, they
taking
are using so much of progesterone.
progesterone, IVF pregnancy.
Yes.
So in those cases, cholestasis has become a little more common than what we see nowadays. And
And
as
here I would like to add IVF with the twin. This is very common.
yes, this is also a study which showed that IVF and twins were
Yes.
also having with progesterone uses, and Udiliv is a treatment of choice. What we give, but if it is a cholesterol, what about vitamin K? Will you give vitamin K or
Yeah.
only when the INR is high?
Vitamin K should be given. Should be given.
What about the deranged LFT? Dr. Devesh?
Yeah.
Yeah, when now the patient has a deranged LFT, we have started her on Udiliv, and
Yeah.
are we worried about any bleeding tendencies in this patient? What about
Definitely, the INR is on a higher side, and in the near course, we are planning for the delivery, whether it is a normal or cesarean. So before that, we have to correct this INR flavor. And if we have time, the
yes,
vitamin K is the best option. Definitely, if it is in the emergency or the urgency, we can use FFP also in this case. But right now, in this case, vitamin K we can use.
yes, because patient is bound to deliver. We need the gestational age of the last previous IUFD was 38. So recommendations say we need to deliver her by 37 weeks, and we need to correct the INR before delivery, and we can keep FFP, very rightly said by Dr.
Actually,
Devesh.
one thing I just want to add, it's just a time-bound management. Like if there is a raised in INR, so according to the time, you can plan your treatment. Like if you have enough time, you can start with the oral this vitamin K. But if you don't have time, you can use IV vitamin K if you have a time of 8 or 10 hours. But in the shorter duration, you better to use the FFP or the prothrombin complex. These are the time-bound treatment for the correction of INR before going for any invasive procedure or any definite treatment.
Yes. And you would give how many two doses of vitamin K standard?
Generally, we in our setup we are using the 3 doses of vitamin K in the OD basis.
OD basis. For 3 days, you would give it.
Yeah, if that time allowed.
So definitely a very practical point you have said that if you don't have time, FFP is the best option. You're not going to acute fatty liver and any thing. This all the differentials which we spoke about, and so with that, I think we have ended. There was one slide, actually I just missed it, about the correction, what Devesh said, that when I just come to that slide, I think it was before this case, it has gone back, sorry, the coagulopathy. So this was the slide which I had put up, when to correct the coagulopathy. So irrespective if there is a overt bleeding in any case, irrespective of the lab report, you need to correct, or if you're planning any surgical or invasive interventions. The platelet count, if it's less than 50,000, you give platelets. If fibrinogen is less than 1 gram per liter, give cryo. If prothrombin time and PTPT are both increased than the control, then give FFP as Dr. Devesh said. Vitamin K also can be given IV, and we can also reserve the recombinant factor 7A, and other things, higher things if we really need it, because we need to monitor her complete coagulation profile and give. So what is required is to do her FDP, PT, INR, fibrinogen, platelet, all levels. So this can be a mantra where we can take care of all our patients, whether they are having dengue or whether they are having a liver problem, and we can treat such patients. So with that, I would just like to end by saying that motherhood is the greatest dream, and we obstetricians should try and make it as a memorable and always a safest option for a patient. And we really don't want all these medical complications to really complicate the pregnancy, where we have so much facilities, or if we don't have the facilities, but we need to know what is right at that time, like how best we can intervene, how best we can give the right medication at right time, and really convince our patient. The preconceptional has become very important, because we gynecologists really know, but what is in our hand is the patients are not getting aware that they need to get themselves screened, or some diseases like we know that thyroid, a minimum like thyroid, Dr. Ashish said. So we need to screen those thyroid antenatally. Preconceptional counseling is so important. If we know a patient of diabetes, like Dr. Uday Thanawala's lecture, so diabetes, all these needs to be tackled, even anemia, everything, if screened preconceptionally, we will really be giving a very safe outcome to the patient, because when everything is under control, a whole process becomes smooth. But if there is no control, then everything gets out of control. So with that note, I would really thank the Jabalpur Obstetrics and Gynec Society. We really had a good discussion about challenging cases, because medical disorders is very vast. We tried to cover the salient features, and questions were asked, so that we get actual take-home messages rather than going into the detail about that cases and everything. And a lot of practical points by all the panelists. I'm really very thankful to all of you. We had a great discussion. Thank you, Dr. Anuradha, Dr. Kaveri.
Thanks a lot.
Thank you so much, ma'am. I really congratulate Madam for moderating so nicely and wonderfully this very hard topic actually for all obstetrician, I feel, because like one of our experienced obstetrician, even she is even saying that it is really difficult to manage few patients at a point of time. So being we as a learner or beginners, we really face such challenging cases, but it is really a teamwork which always be obliged, because now we all have learned that medicine is a branch of teamwork, and we need to join our hands with other specialties. So of course an intensivist can take care of a woman far better than a simple obstetrician, of course, and physician can take care of these hepatitis and help when we collaborate with them. It really gives a one acceleration in the management plan when we join with hand with some specialists other than our branch. And anyways, obstetrics says that always call for help and take a help of your colleague rather dealing alone and thinking of your superiority. It is always to join with your colleagues and make medical disorders, all challenging medical disorders, to come out with a successful mother and safe mother and a baby outcomes. So I congratulate ma'am, and I request all the participants to download their certificates meanwhile also, because it is online available. You can download your certificate when you are registering. You can see a link there for download certificate. All of you can receive your certificate. And since medicine is ever learning branch, and we are dealing with two lives. We need to understand that teamwork will really help all of us, and today's webinar was wonderful. I really thank Dr. Uday Thanawala sir, who took the case of diabetes for us, because it is always learning branch. Diabetes is like always a fearful thing for obstetrician, because I being obstetrician, I have also faced cases with sudden IUDs or sudden uh, 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 big size babies and all. So this is really thing where we need to control the diabetes of a mother, because nowadays mother are becoming quite late in getting pregnant, and meanwhile they are coming with so many medical problems like hypertension or diabetes or thyroid disorders. So sir has taken very nicely this talk, and we are thankful to Dr. Uday Thanawala sir. And of course, isominization we should not forget ever, because RH incompatibility can take uh, can make a bad obstetric history as well. So Dr. Archana Verma, who has enlightened us with her talk, I am thankful to Archana Verma madam, and I also thankful to our eminent chairpersons, Dr. Nisha Sahu madam, Dr. Neena Srivastava madam, our past president Nisha Sahu madam. She has always been working in anemia and medical disorders. Dr. Neena Srivastava madam was ever enthusiastic, also working in Menopause Society as secretary. Dr. Viva Gehlot madam, a senior obstetrician, always with full of knowledge. Dr. Sangeeta Srivastava madam, our recent past president of IMA and our past president of Jabalpur Society, full of knowledge. All the chairpersons, they were with us, they are still with us. I thank to all my eminent chairpersons. I thank Dr. Ashish Dhingra sir, who took our invite for this panel discussion. I know sir is always busy with his national international webinars, but he could took out time for Gynec Society also. Thank you so much sir.
Thank you very much for your kind invitation, and the discussion was very nice, and I enjoyed it. Dr. Komal madam has drive the show very well. Congratulations to team Jogs Jabalpur, and they are very enthusiastic. These people have energy throughout the year, and in the age of any consultant in age of 50 or 25 or 30, the jobs is always glowing in all over India, and they always get the awards. And I congratulate them from the bottom of my heart. You keep on working like this, because I know that I am also an academic person arranging the conferences for the academic feast. And today also I enjoyed a lot this discussion. So thanks a lot for inviting me here.
Thank you so much, sir. Thank you, sir. I thank Dr. Devesh Kumar, sir, eminent intensivist in our city, and we know his work are always obliged by so many obstetricians. Thank you, Devesh, sir.
Thanks a lot, Dr. Kaveri. Thanks a lot for the very nice words. Even sometimes I confuse this is for me or anybody else. Thanks, Jock. Thanks, Jock, for the invitation. It's a very nice talk, and I feel very. You can say I feel very young while I'm attending this webinar. The age is reduced by 10 to 15 years back during my PG time. Thanks a lot.
Thank you so much, sir. And I really thank Dr. Aditya Parhar, who took immediately my call when I said, please, you have to attend this as panelist. And he just took my invitation without any hesitation. I think he has joined first or second time the JOGS Jabalpur Society. Thank you, Dr. Aditya. I am also thankful to Dr. Manik Panse, madam, a senior obstetrician whom I really wanted to be on the platform because we want your experience, ma'am. Seniors have more experience than we all, and really we are thankful that you shared your experience and your knowledge with us through the panel as well. I thank Dr. Nidhi Jain, madam, who is with us and really enlightened with her knowledge as well. I really thank Dr. Roma, our treasurer, for making the panel a wonderful one. Thank you so much. And at the last, again, I thank Sana and Bharat Serum as well for making the webinar a successful one. The TOG team, I also thank Dr. Parag Biniwale sir and Dr. Mandakini Meg madam for giving us ICOG credit hours. I congratulate again Komal Chavan madam, and madam is organizing anemia in pregnancy enclave also. So we all Joxians are supposed to join that. I request all the Joxians to participate in large number. There is contest also. So many. I am floating the messages in group. Kindly go ahead with slogan, poster, skate, rangoli competitions. All are going on. So kindly, all of you are requested to show your talent. Everybody, all of you, thank you so much. Thank you, Anuradha ma'am, for making this wonderful talk and wonderful one. Thank you so much. Thank you, ma'am. Thank you, Komal ma'am. Thank you so much.
Thank you, ma'am. Thank you.
Looking forward now. Send entries for the anemia pregnancy campaign.
Ma'am, we are working. Ma'am, we are working. We are doing social.
Kaveri does very nice acting. I remember your session. Are we offered? Session. I don't know. Session. Are we offline?
No,
No. We are online, madam. We are online.
We are online.
No. Huh? Suppose make offline.
Offline
Okay.
Yeah, so I remember Kaveri in Hyderabad. She was doing acting. Dhanno.
Support, please stop the live.
Do you remember that? So I want a skit from you now.
Definitely, ma'am, you will get.
In Ramoji Film City, do you recollect that?
Yes, ma'am. Yes, ma'am. Definitely. Thank you so much.
They had chosen her from all the people. They had chosen Kaveri to act. She was made the actress, the lead actress.
Thank you so much, ma'am.
That was in 2000, I think 2010 or 11.
Yes, ma'am. 11.
Madam, she's the main role behind getting the prizes for the skits. She's our director.
Yeah, so see, I know the talent. See, I'm upping the right person now.
So I just float the theme to them, and she's through with the direction and everything. Madam, it was lovely to have you. Thank you so much. And
thank you. I really enjoyed. I think it was a real pleasure to meet all of you and interact with all of you. Okay. Thank you, Sana. Thank you, session.